All right, please, shall we pray? In Jesus' name.
Amen.
Our Heavenly Father, we give you all the honor, great praise, and glory for a wonderful day like this, that MWAN again has maintained her leadership role in the fight against cancers in Nigeria. We thank you for what you have used MWAN to do in this realm for the past 47 years, and we thank you that this year, 2023, is no exception. Lord, we know that you are with us. We know you are with the leadership of MWAN, led by our able national president, Dr. Lilian Adekemi Otolorin. We know that you are with all our speakers. We know that you are with all of us who are here to listen. And we pray that as we live, we will not just be hearers, but we will be doers. Thank you, Father in heaven, that HPV is now, vaccination for HPV is now in the schedule of immunization in Nigeria. Lord, it was a fight that came on for so long. And because you helped us to achieve that, we know that everything we desire that will emanate from this deliberation today, you will also help us to achieve it. To you be all the honor, praise, and glory as you guide us to have a successful epoch-making event. In Jesus' mighty name, we have prayed. Amen.
Amen. Amen. Amen.
National anthem, please. Can we all rise?
Thank you very much. I think we'll just start without much ado. I wish to recognize our chairman for today in the person of Professor Isaac ADEWOLE, a professor of gynecology and obstetrics here in the University College Hospital, Ibadan, a former Minister of Health of the Federal Republic of Nigeria, a former Vice Chancellor of the University of Ibadan, President of the African Organization for Research and Training in Cancer, and the only Nigerian professor appointed as member of Council of the Association of Commonwealth University. Please join me to welcome Professor Isaac ADEWOLE. Sir, can we have your opening speech, sir? Thank you so much for joining us.
Thank you so much, the President of MWAN, national officers, including the immediate past President, who led us in the opening prayer. I must express my sincere gratitude for the honor done to me through the invitation, requesting that I chair this special webinar. It is special for quite a number of reasons. Special because we are dealing with two important causes of premature mortality among women worldwide. They both represent significant health problems in various parts of the world. In fact, the latest global count indicated that breast cancer is the #1 cancer globally, while cervix is #4. On the African continent, cervix and breast take either the first or second position. And so in many of the countries, particularly along the West African coast, it is breast followed by cervix. When you go to East and Southern Africa, it is cervix followed by breast. So both of them play a significant position as the leading cause of mortality and morbidity in various parts of the world. The report also indicated some stabilization in terms of the incidence and mortality. And therefore, there is need for us as healthcare professionals to do something tangible to inform members of our various communities about the risk associated with the two cancers. Let me say up front, the most important risk factor for breast cancer is being a woman. But breast cancer has also been reported in men, although the incidence is really not common. So once you're a woman, that is a significant risk factor. And so we ought to educate our women and men by extension, particularly in societies that are dominated by men, that they needed to encourage their wives and assist them to go for screening. And so the title of today's webinar, Escalating Breast and Cervical Cancer Awareness, Risk Assessment and Screening, cannot be more appropriate. It is germane, it is topical, it is relevant, and I want to commend the leadership of MWAN for picking this important topic as a subject for a webinar. I'm quite convinced that it will go a long way, particularly when we look at the array of eminent scholars selected to do justice to the topics. People like Professor Obajimi, Professor Alatise, Dr. Awolude, Dr. Awolude, Omishore, Betiku, Idowu. These are seasoned scholars who have done a lot of work, published quite a lot of articles, and also involved with clinical and community work in this area. I'm sure all of us will richly benefit from their store of knowledge. And at the end of the day, I want to make a plea. And that plea is that we must not keep this knowledge within us. Let us download it. Let us spread it. Let us share it according to the popular refrain on WhatsApp platforms. Someone will say share it 10 times, share it 5 times. And I want to say jokingly that if you share it 10 times, you will be richly blessed. You will have prevented quite a number of people from developing cancer. Congratulations to MWAN. Congratulations to Nigeria. And I want to thank you for putting this together.
Thank you very much, sir. We appreciate you, man. Yes, well, I guess I was in a hurry to start the program. Please permit me now to invite our national president, Dr. Adekemi Lillian Otolorin to give us our welcome address and formally welcome us to this webinar. Thank you.
Thank you very much. To God be the glory. Good afternoon, good evening, good morning, wherever we may be in this space. It is my pleasure and honor to welcome you to this webinar on our cancers affecting women's health. As you have heard from our minister, there are so many issues surrounding women's health. And in MWAN, we have a culture. And that culture, it is statutory that at each biennium, we organize a webinar, a town hall meeting, or outreach as national to give awareness and also to impact by donating money for cancer patients. Today, the M1 biennium of 2021-2023, we are out to have this webinar. And I want to welcome our special minister, our special former VC, our special former provost, supporter of women, and a man who keeps his promise. Please give a round of applause to Professor ADEWOLE. If we can rightly remember, he was the chairman at the biennial conference opening ceremony in 2021. Thank you, sir, for keeping your word to partner with M1 and to support us all the way. We welcome also Her Excellency, Dr. ZAINAB BAGUDU, the advocate, global advocate for cancer, and also an M1 member and the former wife of the governor of Kebbi State. She is everything cancer. She's ready to support at all times. She's ready to donate at all times. She's full of empathy. And it's not just supporting all women to get cancer eradicated. Again, we have the national president of the Nigerian Society of Cancer, our boss on our platform and in Nigeria, all societies on cancer and individual, Professor Obajimi. To the glory of God, we are all reaping the fruits of our labor. When we were much younger, Professor Obajimi was my mentee. Now, my mentee has turned to be a great mentor. She has been impactful. She has offered to serve, even a minute to the time, whether at pastoral level or professional level. She's always there. Former NMA chair in Oyo, former head of department, UCH Radiology Department, Dr. Betiku, Dr. Idowu, Dr. Awolude, and Professor Adejumo, who is not here. We thank you very much, for we are going to benefit from your wealth of knowledge. My colleagues, M1, surgeons, pediatricians, nurses, physiotherapists, women in all spheres. What can we do without knowledge? Knowledge is very key. We realize that the more we look, the less we see. And we do outreaches in M1. We are in all the 36 states plus Abuja, but we are still getting these cancers, even amongst we doctors. Should it be a 2-year event, that is October and February? No. I think we have to promote ourselves. It has to be every month, and we have to be our sister's keeper. Why in the year 2023 should we find 4th-degree uterine prolapse in our Quran? Is it that women, they have nobody to talk to or to share their experience, that such a woman kept that lesion for long, fungating? Or why are you still having stage 4 breast cancer? Are we not shouting enough? I think we need to start another initiative. Women Helping Women initiative. You need to partner with a fellow woman, till she slaps you. Have you checked your breast? Have you gone for cervical screening? We need to catch it young, because that is the clue. I will not bore you too long. We are winding up as a biennium. We'll be handing over to Professor Ogu in Port Harcourt. But MWAN is a continuum. I want to use this occasion to tell all our partners, collaborators, governments, and especially my national executive members. They have expended time, given energy, resources, whether convenient or not convenient, to showcase M1, because statutorily, M1 National must be impactful. We must show the way. And I want to thank the state executives. They have followed clearly and properly. They have done many of these programs, and they are sending their report. I want to thank partner NGOs, because together we move the health of the well-being of everybody better. Once again, I want to thank the media practitioners. Without you, people won't know what we are doing, and they won't be able to benefit from the knowledge. Once again, I say thank you for everybody online, for your patience while we were getting the technical issues right. God bless us also. Thank you. Bye.
Thank you very much, Ma. We appreciate you. Please, I'm not sure if Her Excellency, Dr. ZAINAB BAGUDU, is online, the wife of the Honorable Minister of Budget and Economic Planning. She's our special guest of honor. Or did she send any representative, please? Okay, if she's not yet with us, please can we have Dr. ADAMU UMAR, the President, Cancer Society of Nigeria, give us his goodwill message.
Hello, very good afternoon.
Good afternoon, sir.
Am I audible?
Yes, you are.
Fantastic. Good afternoon, Prof. Fantastic. The former Minister of Health, our very own Professor Isaac F. ADEWOLE, the M1 President, Dr. Mrs. Otolorin, executive members of the Medical Women's Association of Nigeria, and our seniors, our elders, distinguished participants, a very good afternoon. Clearly, for partner, for being a very proactive body, especially in the area of cancer awareness, cancer screening services, capacity building of members, and indeed, in maintaining the national visibility of the amazing efforts of our medical women in Nigeria. I bring to you all glad tidings from the Nigerian Cancer Society, the umbrella organization for all cancer-related NGOs. We have a lot of Amazons, a lot of very inspiring women doing a lot of wonders. The president made mention of Her Excellency, Dr. Mrs. Shinkafi Bagudu, the immediate past First Lady of Kebbi State, our global cancer ambassador who is on the board of the Union for International Cancer Control, who actually gave it a shot to be the #1 cancer person in the world last year as a build-up to the World Cancer Congress. We couldn't make it to the #1 seat of the Union for International Cancer Control, but the journey is a continuous one, just like the president of M1 stated. M1 is a continuum. Whether she's president, whether she hands over, she still maintains her membership of M1 and her contribution will still continue. And we have a lot of M1 members that are very active within the Nigerian cancer space. We have quite a number of them, including Madam President herself, the likes of Dr. Fatima Zara Mairami from FCT, the likes of Dr. Aisha Mustafa from Kaduna, the likes of Professor Ima Obong Ekanem, a former past president of the NCS, some of whom are life members of the Nigerian Cancer Society, just like our father, Professor ADEWOLE is. Professor Isaac ADEWOLE is someone that is very passionate, in fact, more passionate to a lot, more than many women out there when it comes to the elimination of cervical cancer. He is our global icon when it comes to the issue of cervical cancer elimination in the world. And I want to sincerely, on behalf of the Nigerian Cancer Society, appreciate M1 for sustaining the momentum, for ensuring that there is continuity in the activities that are geared towards healthcare delivery in Nigeria, that are geared towards universal health coverage, that are geared towards ensuring that there is active collaboration within the Nigerian healthcare sector, because collaboration is the panacea that will take us towards universal health coverage. The various screening services organized by M1, both at the national level and across the state branches, is a very key ingredient that we need as cancer advocates to ensure that we create knowledge, we create awareness. We try to close the awareness gap, because awareness is our #1 problem when it comes to cancer in Nigeria. The myths and misconceptions that are out there. I want to believe that webinars like this will ensure that we have an amplification in the awareness creation spectrum, will ensure that we have a lot of capacity being built through the M1 structure, so that there will be a purposeful drive at addressing the myriad of challenges. The array of speakers that are on this call today, I'm sure will do justice to the topics. And by the end of the webinar, it is my belief that each and every one of us will have something to take home, will have a value addition that will be derived from this webinar. So once again, I want to sincerely thank the national leadership of the Medical Women's Association of Nigeria for inviting me to be part of this event, and for assembling this array of speakers, and in fact for convincing and having our father, Professor ADEWOLE, to be the chairman of this occasion. This is indeed a very laudable initiative of M1, and I want to assure M1 that we will continue to partner, we will continue to collaborate in every areas possible towards cancer eradication on the surface of the earth, not only in Nigeria. I wish M1 very well ahead of their biennium coming up, I think in September, and I want to congratulate the incoming president and her executive, and I hope and look forward to a more robust partnership with M1 in the coming years. Thank you very much once again for having me. Good afternoon.
She has mentored a number of upcoming younger generation of radiologists, resident doctors, consultants all over Nigeria, and in fact in the West African sub-region. She was one of the pioneers and driving forces behind the establishment of the Breast Imaging Society of Nigeria. She has repositioned breast imaging in the country. Like I said, though she's retired, but she's always with us, in every activity concerning cancers generally and breast imaging in particular.
Please welcome Professor Millicent Obajimi as she starts with her lecture. Thank you so much, ma'am, for joining us.
Thank you very much. Thank you very much, Dr. ADEWOLE. I hope I can share my screen now. I need to share my screen so that I can.
Dr. Ilori?
Dr. Ilori, Abinu. Sir, Your Excellency, past Minister, former Minister of Health, Professor Isaac ADEWOLE, National President, Mrs. Kemi Otolorin, the national team and her ESCO. I just welcome all of us this morning. I appreciate all the co-speakers that are available to share knowledge this morning, and for all the people who have joined us online. I am grateful we are happy to share our knowledge with you. I want to thank the EXCO for allowing me to speak, because as Dr. Ilori said, I am retired, and I think I would have thought that the younger ones should actually be very much active. So I am very grateful. I thank you for welcoming me. I thank you for allowing me. I'm trying to see if I can share my screen. I'm still finding it a bit not, it says the host has disabled participant. I need to be allowed to share my screen. We are grateful to have Professor ADEWOLE on board, even though he says he might be leaving early. He is the great-grandfather of cancer in Nigeria, even though he is known for cervical cancer. But in the aortic, he has been the past president, and he has taken several laudable steps to escalate breast cancer awareness in Africa and the West African sub-region in particular. We always glean from his knowledge, and we are grateful that he is always accessible and available. All right. So I am. Right. Thank you very much for allowing me. This morning, I'll just take a topic, imaging as an invaluable tool in escalating breast cancer awareness. As we have been told from all the introductory messages, breast cancer is a global health problem. Incidence keeps increasing, and it is increasing. Also, it is increasing locally in Africa and in sub-region. That is why a whole month is dedicated to breast cancer awareness, to escalate awareness amongst women, especially in the rural areas. Even though we seem to be showing awareness in the cities, we found that women, even in metropolitan cities and towns, are still not quite accepting this message, and they are not doing too well with breast cancer screening. But we hope that the more we talk about it, the more the acceptance of women, especially the educated ones. Because if we, the educated ones, accept mammography, then we can always disseminate it at any level. The whole essence of breast cancer awareness is prevention, early detection, appropriate management, and improved quality of life.
We cannot see your screen, Prof.
Wow, you cannot. My screen, I can see it here.
Yes, but we can't see it.
Okay.
From my end, what I could see is just a vertical image.
This one?
Same thing to us here. I can't see it, so it's just a
You
vertical.
can't see it.
Yes, probably you stop sharing and you reshare again, man.
Okay. Let me stop sharing. And let me share. Okay. Okay. Let's go. Computer. Wow. Share. Can you see it now? Still not?
Not yet.
Stop sharing. Okay.
But
share screen.
we can only see your face.
Wow. How about this? Share.
Yes, you are sharing your face.
No, I'm not sharing my face. I'm not sharing my face. Wow. Can you see now?
Well,
are you able to?
It's coming. It's coming.
It says you have started.
All right.
Yes. You are there now.
Yeah, I am there now. Okay. It's still loading. I guess it's loading.
Hello?
It's loading.
It's loading now.
It's loading now, yeah.
Well, we can see it. I can see it, man. Imaging an invaluable tool for breast cancer awareness and screening in the Nigerian women. So we can see it, man.
All right. I'm trying to see how I can, change the one of, okay, let's go. So I started by the introduction saying that breast cancer is still on the increase, even in developing countries. I also emphasize that screening is the goal of prevention, and it is the major aspect, the major outreach amongst women for now, because we've found out that even in the metropolis, women who are educated and who should actually be screening for breast cancer are not yet available. There are very few of them that come in except they are symptomatic. So breast cancer screening is to ensure prevention, early detection, appropriate management, and improved awareness. As we said, it's the leading cause. Even in Nigeria, over 100,000 cases are reported annually, with about 70,000 annual deaths. It is still responsible for 50% of cancer deaths in our country. But what are some of the reasons for the increased incidence? Urbanization, change in habits, lifestyle, education, parity, contraception, diet, and of course, our environment. We know that when we look at this increase, urbanization, habits, activities, education, which prevents women from getting married early, so that ensures delay in first birth, and so on and so forth. Parity in the current, the younger ones now prefer to have one or two children. They don't want to have too many, and we know that the more the number of children, the more children we have, the better protection from breast cancer. Contraception too. There has been studies that have shown that some forms of contraception can be risked for breast cancer. Diet. Most of our diet styles have changed and have led to risk factors of breast cancer. What are the peculiar features of breast cancer in developing countries? Usually premenopausal. It occurs in younger women who are actually in their productive years, who should actually be holding up their families. And of course, there's a strong family history. I remember we once had a lady who presented at 28, her mother had presented at 52, and her grandmother at about 68. So there's usually, we have strong family history even in our own setting. There are lack of screening facilities, poor awareness of breast cancer, which leads to late presentation, limited education resources for early detection. Most women do not have appropriate information or knowledge about breast cancer, so they seek help in the wrong places. Limited access and funding. Of course, we know that breast cancer management is very expensive. Most women are not able to afford it, especially women who are not empowered. Hereditary cancer can be, we try to look for high-risk women. Women and hereditary breast cancer can be identified in families where several close family members have been diagnosed for ovarian cancer. A number of generations are involved. Family members have been diagnosed young. Both breasts have been involved in breast cancer. And of course, a male relative has also had the disease. And this is a typical picture of a late presentation. Other features of breast cancer in the Black woman is the interval cancer. She does mammography. Within 6 months, she begins to present with an aggressive cancer. It was not identified in the previous screening, and in 6 months or 8 months after, there is an interval cancer. The cancers are usually very aggressive because it's been known that Black women have, they tend to have triple negative cancers on basal cells. The immunochemistry is usually triple negative, and therefore they cannot benefit from the current drugs that are used to manage breast cancer. They have to be treated according to the immunochemistry results, which makes breast cancer management a lot more personal. Risk factors are anything that will increase chances of having the disease. So we have a number of risk factors here: diet, ionizing radiation at the time of development of the breast, hormonal changes, young age at menarche, late age of menopause, nulliparity, old age at oral contraceptives, lack of breastfeeding. The more children we have, and the more immune. Benign breast diseases also occur in women, and they tend to increase with some of our habits. Family history, as I said earlier, is also very, very important. This is usually with all the structures in the breast can develop breast. Terminal lobular units. That's the terminal lobular units. The stroma surrounds it. This is the interstromal tissue. These are the main ducts, lactiferous cell ducts. All of these areas can develop breast cancer. And of course, we know that breast cancer, the essence of screening is to pick breast cancer at this point, when it is pre-malignant, when there is atypical ductal hyperplasia, or when there is intraductal hyperplasia. All of these two are pre-malignant conditions. So the essence of mammography is to pick them at this stage before they deteriorate into ductal carcinoma in situ or the invasive ductal carcinoma that begins to extend and have locoregional extensions. When we pick them this early, then while we pick them at this point, screening is usually very invaluable. However, by the time patient develops ductal carcinoma in situ or the invasive type, we realize that the patients are not readily helped. This graph shows us the essence, the value of mammography. We find that and in women above 50, the malignant disease is you can only pick a low number, whereas when we do mammography, the bar on mammography increases, and more cancers can be picked by mammography. Even benign lesions, more of them can be picked by mammography. And when we look at nipple discharge, actually mammography does not do much about that except to do the ductogram. So mammography ensures increased detection of breast lesions, whether benign or malignant, at any age. So every woman must be advised. So these reasons are compelling. They provide a compelling argument for escalating breast cancer awareness amongst women. The primary disease that can be asymptomatic, can have pain, nipple discharge, skin changes, or palpable lump. But when the original disease occurs, we can find them either in the axillary mass or in distant metastatic areas. Breast cancer prevention includes health awareness campaign, as we're doing this morning, national breast cancer screening policy that we're still working on in Nigeria. There's no current policy, and of course, we have to encourage screening all the way. What are the principles of screening? The woman comes in as an asymptomatic woman. The symptomatic woman continues to progress with the disease, while the asymptomatic that has presented herself for screening will be screened. And if anything is found early, it is treated, and that will reduce the mortality and morbidity of the disease because of early detection and prompt treatment. So breast cancer, what is the policy? There must be yearly mammograms, but in our setting, because of affordability and availability, we recommend maybe once in 2 years. But most countries is once in a year when they're 40. And of course, a woman must start her breast self-examination at 20. And every 3 years, she must have a clinical breast examination. So a clinical breast examination once in 3 years, between 20 and 39 years, and of course, is a breast self-examination at 20. However, asking a woman to come in for a breast mammogram at 40 is only when she doesn't have a family history. When there's a family history, the woman must present herself 10 years below the age at which the family member presented. For example, if a family member presented at 48, the woman should be available for screening at about 38 years so that she can be adequately monitored. And if the family member appeared at 38 and the 10 years will just be 28, such a lady may not have mammography, but we can examine with ultrasound and MRI to ensure that we monitor such a woman and ensure she gets the best of a follow-up. So screening mammography, in diagnostic mammography, it's usually very specific, about 80%, and it allows us to do wire localization to help the surgeon to localize the lesion. It also helps stereotactic biopsy, so pathology, reporting, and helps us to also examine the ducts in the breast for any possible lesion. Mammography in combination with other imaging modality, for example, ultrasound, increases incidence of detection. Why is mammography important? This is usually the timeline for the tumor. When the tumor begins, it's usually very occult. But in between the first and third year, it's at the point when it can be detected by mammography, because beyond the third or fourth year, it becomes clinically evident, and this can lead to possible regional, difficult, more expensive management and local regional metastasis. So we usually like to pick the lesion in its surgeon time between the first year and the third year. So mammography is sine qua non for breast cancer detection. Usually we have two views, CC and MLO, but when we are not able in an equivocal mammogram, we can do other views. In screening mammography, there are no signs, no symptoms. There are just two views. In diagnostic mammogram, the woman presents either with a lump, some pain, the nipple discharge, probably there's a skin change or skin color change, and of course, some women with implants can also present for diagnostic mammography. And for such patients, we certainly have more. That's a typical mammogram, and that's an ultrasound unit. The ultrasound is so important because it is peculiar in that it can characterize the tissue. It can differentiate between the solid and the cystic tissue. It helps us with interventional procedures when we can do core biopsies, guided biopsies, and also is invaluable in pregnant women when we cannot compress the breast as a result of her lactation. Women with implants also benefit from mammography if the implant cannot be effectively rolled away for imaging. So breast ultrasound, when combined with some mammography, increases detection of a lesion. It is fantastic in differentiating the solid and cystic lesions. These are all the devices used for guided tissue biopsies. You can either be guided by ultrasound or by mammography or MRI. So we tend to want to escalate investigations if we have facilities for MRI. But otherwise, we can do an ultrasound scan if we found anything on the mammogram, and we can always have a second look. Of course, all of this will be discussed at the multidisciplinary tumor board, which is the current standard of managing breast cancer. You know, stakeholders come together and they brainstorm on each patient, because breast cancer is now, you know, women are now offered personal treatment that is peculiar to each woman, the tumor type, his immunochemistry, and also acceptability of drugs. So that makes it easier and gives better results. MRI guided, ultrasound guided, and then report samples are taken for histopathology. Once we have imaged, we are able to categorize the lesion, whether it is a normal study or it is a benign image. It's probably benign. And of course, categories 4 and 5 are usually the ones we tend to run after. Category 4 is suspicious anomaly, and category 5 is highly suggestive of malignancy. However, category 0 is an incomplete study. The result is neither here or there. We tend to want to do a second look or a short interval follow-up. Breast cancer prevention, you know, methodology, the surgeon will talk about that. After diagnosis, you know, the radiologic biopsy confirmation, pathologic histoimmunochemistry status, and then the option, then the treatment option can be chosen. Challenges in mammogram equipment, radiological, pathological, limited data available, psychological, cultural beliefs. We found out in Ibadan MDT that most women do not want their breast to be exposed. They have to get the permission of their husband. Sometimes when the malignant lesion is detected, they run away. They don't come back for treatment because they said their husband will not want a single-breasted woman. And so they also have issues with cost. So they prefer to go for alternative treatment. And before we know it, they come back with very late fungating lesions. So we still have we still have issues with women accepting the conventional medical treatment. Most of our women are still ignorant of the disease. They diagnose, they don't come back for follow-up. They probably believe that they cannot afford treatment, or they can get treatment elsewhere. There's also issues of manpower, because we need to have imaging scientists, radiologists, pathologists, as well as the surgeons, very important stakeholders in managing breast cancer. Some women are shy to expose their breast, even when they notice an anomaly. If it were a lesion in the eye, you know that everybody would have identified that something is wrong with your eye, but the breast is permanently covered, so they don't come out to say anything. Screening and treatment facilities are not readily available to our women. They have to come to the cities to get them done. Many women prefer to take alternative therapy. They tell us that they have some form of a diet or some form of treatment. They have gone else, they've gone to the church sometimes, and they've gone to the mosque to seek treatment, or probably to any other alternative type of therapy. The high cost of screening and treatment is prohibitive. In the UCH currently, there's a new machine there, and the cost of mammography is about 10,000 naira. That most women may not be able to afford, except they are really empowered financially. So we still have issues with cost of cultural and spiritual taboos. They don't want to make some women don't even want men to do their mammograms. And in some centers, it's only our male counterparts who are there to do mammography. And they don't want their breasts to be exposed to any man. What is the way forward? National policy for cancer, breast cancer, subsidized cost of management. Currently it's unaffordable. It should be subsidized so that many women can key into it and benefit from it, just as it was done for HIV. It should be included in the NHIS, breast cancer, especially screening. If breast cancer screening is included in the NHIS scheme, more women will come in for mammography. We are trying to see that more members of staff in UCH should come in for mammography, but the scheme. Most of them cannot afford it. They wish they were on the NHIS scheme. So we are hoping that sooner or later it will be included. There are drugs and also total management. Surgery is very expensive. Chemotherapy is also expensive. Some women have to take the neoadjuvant before treatment proper starts, and they cannot afford it. So training and retraining of care providers. Most of us have been trained years back, and we have tried to train the trainers. But I think it is important now for training and retraining, especially now that there is escalating awareness. People should come to centers and find qualified radiologists, radiographers, pathologists, surgeons, and oncologists to manage. We must encourage breast cancer research, because we found out that breast cancer is in the black is totally different from that in the Caucasians. We want to provide robust data to ensure that we can get the appropriate drugs for their type of cancer. They probably produce vaccines, or we can also identify risk factors in these women so that they can be helped. They can also benefit from locally acceptable drugs. Conclusion: physicians should make an effort to identify high-risk families with significant family history. There is need to escalate breast cancer all the time, not just the month of October. Breast self-examination and clinical breast examination should be encouraged in young ladies. When there is any symptoms, they should be told that the mode of examination is ultrasound and not mammography. Early reporting of breast symptoms must be emphasized. They must not go elsewhere short of attending a clinic where there is a qualified medical practitioner. What is the take-home message? Breast cancer cannot be prevented from occurring. Changes at the early stage will not be visible to the eye or palpable by experienced surgeons. Mammography has been proven and tested. Examine your breast regularly, educate other women around you, report any breast anomaly. Thank you for your attention.
Thank you so much. Please appreciate Professor Millicent Obajimi for the very lucid presentation. Thank you so much, ma'am. She has emphasized the fact that we need to present early, the importance of early imaging in diagnosis, the challenges of late presentation, the issue of manpower, inadequate manpower, which obviously is worsened by the Japa syndrome now, and the fact that we should counsel our patients to examine, and even we should examine our breast regularly. Thank you so much for the beautiful lecture, ma. Thank you, ma. So on this note, we'll call on Dr. Adeleye Dokas Omishori, who is a senior lecturer in the University of Obafemi Awolowo University and an honorary consultant radiologist in the Obafemi Awolowo University Teaching Complex. His interest is in breast imaging and interventions. Thank you so much. You are welcome.
Just an interruption.
Thank you, Ma. Can you see my screen, please?
Just an interruption, please. An interruption.
Professor Bajimi has to stop sharing.
Yes, so I want to stop sharing.
I wish to
Shared sound. I'm trying to stop sharing before I can get to. Okay, maybe I should just leave.
one of the key issues.
It's not as loud. Okay. Okay, thank you very much. I'll stop sharing. I've stopped sharing.
One of the key issues that we have to address today is how to help the cancer patient. That is the next step. And that is why in MWAN, apart from awareness, advocacy, we must find funds to help them. You can't just stay in a clinic, oh, you have something there, you can go home. Some, they break down, they start to cry. Some tell you right away that they will kill themselves. Some say nasty things. So we need funds to help them. Some will like to do lumpectomy, or ultrasound. So in MWAN, from each state, we ask them to write a list of those who are really indigent and who need help. For these people, we must raise funds, whether it's 20,000 per patient or 30,000. We must do something. This is how to be a sister's keeper. And as such, when we are having the second lecture before our chairman goes, we will have the MWAN Cancer Fund launch. Please be aware, no amount is too small. If you cannot donate today, you can pledge and we'll come round to you to collect the pledge. Thank you very much for being supportive. Thank you.
Dr. Mishore, you have the floor, please.
Yes.
Yes.
Thank you very much, Maz and SARS. I stand on existing protocol. I'll be discussing breast cancer screening for developing countries, what is practicable in Nigeria. I think my lecture is actually supposed to be the last, but because I have to jump off very soon, I have begged for my lecture to come up now. So there will be terminologies I'll be using that other speakers will be talking on when they come after me. So I'm a radiologist in Obafemi Awolowo University Teaching Hospital Complex and a senior lecturer in the University of Ile-Ife. So in 2019, the International Agency for Cancer Research launched cancer screening in 5 continents projects. And it actually collected data on the screening of breast, cervical, and colorectal cancers in the 5 continents. 84 countries contributed data to this project, and 57 of these countries actually contributed data on breast cancer screening. Now, of the 57 countries, 4 countries were actually from Africa, and these countries included Mozambique, Morocco, Kenya, and South Africa. Unfortunately, there was no data contribution from Nigeria. Looking at the choice of screening tests across the continents in this project, mammography was the main screening test in Europe, in Australia, and in the Americas. The Americas consisting of both North and South America. Only 1/3 of Asian programs actually adopted mammography as a screening test. Unfortunately, or in contrast, clinical breast examination was the primary screening test in all African programs that were reported, in the 4 African programs that were reported. However, Kenya combined clinical breast examination with ultrasound and mammography, plus or minus a digital breast tomography, which is a 3D mammography. So some of these programs that were reported actually offered free of charge screening services, while some offered free of charge diagnostic services. 3 of the 4 African programs offered free of charge screening services, and 1 of them actually incorporated, in addition, a free of charge diagnostic services. Now, one other thing was that there was invitation to eligible women to participate in screening programs in European and American programs, but none of the African programs actually offered invitation to eligible women. So women walked in at their own prerogative. And then data collection was done on an individual basis, and Africa, for example, only reported one of the programs collecting data on individual basis. It means that most of the programs were being done and there were no data collection on this risk assessment and clinical outcomes of patients that were being screened. Now, is there a screening program in Nigeria? Unfortunately, no. There's no screening program for Nigeria and in Nigeria. Professor Obajimi also mentioned that in uptake rates in the country, and the rates have actually been shown to be very low. There are reasons that have been alluded to this. There's poor awareness of the disease and its study. Poor geographical access has also been a reason why uptake of mammography is poor. And a recent study that looked at breast cancer screening and diagnostic services across the country showed that the services, the access, geographical access is actually better in the southern part of the country, particularly the southwest and southeast, when compared to the northern divide of the country. And then the last reason also is the cost of the test. And unfortunately, I'll use the word unfortunately, that even amongst female health workers, cost of mammography was also a problem or an hindrance to uptake of mammography screening amongst them. Now, what is practicable for the country? The first is to develop a screening protocol. And there has to be a collaboration between professional bodies, NGOs, the federal screening test that is ideal for a resource-limited or resource-challenged environment like Nigeria. CBE versus the intelligent breast examination, or versus mammography, or versus ultrasound, or a combination of all. Now, different studies have actually looked at CBE in the past, looked at CBE as a stand-alone screening tool or in combination with mammography plus or minus ultrasound. Now, evidences are actually very limited in Nigeria. And so we need to actually have audits of results from centers across the country to see the benefits when it comes to clinical outcomes, when it comes to downstaging of breast cancer with clinical breast examination. In a recent study in Southwest, there was actually a study of the intelligent breast examination device, which is called the IBE device. And it was shown that this device increases the sensitivity of clinical breast examination when it is used in combination with a clinical breast examination. So if we're having a clinical breast examination with a sensitivity of 70%, when used with in the intelligent breast examination device, the sensitivity actually increases. However, the specificity didn't really differ. Now, a study in Southwest Nigeria is actually trying to evaluate the impact of a combination of these screening tests at the community level. And it's combining the clinical breast examination with intelligent breast examination with mammography and ultrasound. And this is being offered at the community level. And at the end of the day, we'll be evaluating the impact of this screening test on outcome measures like stage at presentation, time to presentation, and stuff like that. So what the ideal screening test that should be adopted for Nigeria, now we need to do a lot of work to be able to look at that. However, in my upcoming slides, I'm going to talk about one or two things. Now, what age is ideal to commence screening? We know that in established screening guidelines in literature, the lowest or the youngest age has been 40 years. However, Intekim et al. In Ibadan actually audited breast cancer registries in Nigeria and found out that breast cancer actually begins by the age of 35 in Nigeria and peaks around the age of 40. So for us, the recommendation would actually be that screening should start a decade earlier than that 40 years, which is the youngest age that was recommended to commence screening mammography in established guidelines. So for us in Nigeria, 40 years of age for mammography screening is not likely to work because our cancers are occurring a decade earlier than what is happening out there outside the country. Now, what format of screening is ideal for Nigeria? Is it a population-wide screening? Is it a risk-based screening or an opportunistic screening? A population-wide screening would usurp a lot of resources, and Nigeria is one place that is resource-challenged, and it doesn't look visible for a country like ours. So, however, population-wide screening would achieve a higher screening coverage when you compare it to an opportunistic screening, for example. But is it visible? Do we have the resources to deploy to actually go for a population-wide screening? Now, another way to go is to look at the risk-based screening, in which women that are high risk of having breast cancer are actually invited for screening. That is going to actually offer lesser number of women screening, and so we have resources deployed for less number of women, and so the resources might actually be enough to cater for these women. Opportunistic screening is a form of screening in which you offer screening to a woman that comes into the health system for something else entirely. For example, a woman presents in gynae clinic to evaluate her fibroids, and because she's of screening age for breast cancer, then she's also offered breast screening services. Or a woman takes her child to pediatric clinic for pediatric clinic, and the doctors identify that the woman is of screening age, and she's also offered screening along the course of the child being treated. So what works for us is what we are trying to look at now. Now, a risk-based screening would actually build on local, regional, or national studies that have identified the risk factors that predispose women in our environment to breast cancer compared to the average risk woman. A recent study has actually shown that women that are older than 50 years were 5 times at risk of having a virus 5 lesion on mammo. And women who attained menopause after the age of 55 were 3 times more at risk of malignant pathology, and the risk in them actually doubles if they have had a previous breast cancer. So if we want to adopt a risk-based screening for Nigeria, we can actually build on the results of this study, for example, or we do larger studies at regional level or national level to actually show the risk factors that we can use to...
We want to say that I'm sure you will really enjoy it at the end of the day. So I just want to thank you. Okay. Yeah, so just tell us as you feel, okay? And
Hello.
Yes, thank you very much.
Hello, ma.
Yeah,
Your mic
I will
now
be
muted.
with
Prof.
you.
Professor
And another
Ikeaja,
person
yeah.
Can you
to
hear
Mute your
me?
mic, ma.
And Dr. Adeleke would be
Professor Ikeaja, you kindly
would
mute your
be
mic,
Hello.
ma.
facilitating.
Sorry, can anybody hear me now? I
They
don't
should
know.
mute everybody. Mute everybody now.
Okay, so I was talking about opportunistic screening. There was a study that was done about 2 years ago amongst female health workers, and we found out that just 2 of 10 women, we
Yeah.
found out that just 2 of 10 women, of 10 doctors were, hello, oh my, hello,
She's yet to be muted.
can I go on?
I think the host should mute her. She's still, okay, I think she's muted now.
Okay, so we found out that just 2 of 10 female doctors were actually offering opportunistic screening to women that they meet along their line of duty. And most people actually said that they were subspecialties that they were not having contact with women. For example, the pediatrician would say that their own choice of patients were children, or the dentist would say, oh, the patients were coming to talk about their teeth and oral health. So, but during the recommendations for the study, almost all female doctors, about 98% of female doctors were actually willing to actually start offering opportunistic screening to every patient they come across along their line of duty. So this is something that is practicable, is going to use less resources, and then it's going to be a vertical program. We are going to be incorporating this into existing resources that are already in the health system. We are not creating new systems. So it's obviously going to utilize less resources than trying to create an entirely new program for breast cancer screening. Now, I talked about the study by Adekemi et al. That found out that breast cancer usually begins around the age of 35 in our environment and peaks around 40 years. Unfortunately, women in this age group are young and they have dense breasts. And we know that the fatty breast is the mammo breast. So the denser the breast, the less the sensitivity of mammography to detecting any lesion. So Omidiji et al. And Adekemi et al. Have actually explored screening mammography explored ultrasound as a screening tool for breast cancer screening. And they have looked at this in women that are less than 40 years of age. Ultrasound has shown to have good sensitivity in dense breasts, and they are actually automated systems that have ensured reproducibility of findings. The other thing with development is that we now have mobile health tablet ultrasounds that have ensured point-of-care use of ultrasound for both screening and diagnosis, including ultrasound-guided biopsies. So we actually can have tablet ultrasound right there in the breast clinic being used to scan for screening and diagnostic purposes. Now, there are also new technologies for ultrasound that are incorporating artificial intelligence, and this has increased the sensitivity of breast cancer screening. Such systems are actually going to be deployed to Nigeria very soon for a study that is about to commence. Now, What else is practicable for Nigeria? Mobile mammography units and portable ultrasounds. Now, we have one of the reasons why optical mammography has been poor in Nigeria was geographical access. We have underserved, hard-to-reach Nigerian communities that are far away from secondary and tertiary centers that offer specialized breast services. So having mammography, mobile mammography vans that actually can access these places to provide these services would actually help to overcome that barrier of geographical access. So one other practicable thing is to have mobile mammography units and portable ultrasound for the hard-to-reach and far-to-reach Nigerian communities. In summary, I've looked at the status and performance of breast cancer screening programs across the continent. I have said that in the African continent, only 4 countries contributed data to that project, and Nigeria was not even part of this country. I have said that Nigeria has no formal or no screening program. And I've said that mammography, which is the modality of choice for breast cancer screening, has had low uptake rates in Nigeria because of poor geographical access, poor awareness of the disease and its screening methods, and the cost of the investigation. I've looked at what is practicable for the country, having a risk-based screening, or having an opportunistic screening, or using ultrasound for those that are in the young age group because of their density of the breast, and also looking at deploying mobile mammography units and portable ultrasounds to hard-to-reach and far-to-reach Nigerian communities. I would like to say thank you for your time. Hello.
Thank you so much, Ma. Thank you so much, Ma. We appreciate you.
Thank you very much, Ma. We appreciate.
Yes.
Thank you for the brilliant presentation. She has brought to our notice that the uptake for mammography is poor, and very disheartening to note that there is no formal screening program for breast cancer here in Nigeria. And some of the way forward is to have portable ultrasound units or portable mammograms that can be used in less or hard to reach areas. We appreciate you so much for this lecture. Thank you. Another round of applause for her, please. So, like the national president said, on this note, we're going to have the launch of our cancer fund, which will be anchored by the national coordinator, Dr. Gbemi Daramola.
Good afternoon, everyone. All protocols duly observed. We will take a few minutes to quickly do this. Like we've heard from the first 2 speakers, the incidence of breast cancer is high in Nigeria. Screening is not available. Screening protocol is not available. And so women are dying from breast cancer every day, many because they cannot afford to access care. And so at this point, we want to call on everyone to donate to this cause to save the life of, even if it's just one woman, from dying from breast cancer. I want to start from please don't leave now because I'll be going through the names. Wow, this thing is not what happened. I'll be starting from my teacher, the former Minister of Health, Professor. He was my teacher, and at some point, he was even my employer, Professor Isaac ADEWOLE, who has been described as a global icon when it comes to cervical cancer. Sir, Oh, he left for another meeting. Okay, I've been informed that he has pledged a handsome contribution. So I'll be going through the names. Next, I would like to call on Dr. ADAMU UMAR, the President of the Cancer Society of Nigeria. Like you said in your opening remarks, you are passionate about breast cancer, so I'm sure MWAN calling on you on this occasion, you will not be tired of giving to this cause. Dr. ADAMU UMAR. The last time I checked, there were 85 names. Now there are 75 names. Looks like some people are running away. Is Dr. ADAMU UMAR still online? Okay. I've also been informed that he has promised a handsome donation at another meeting. Next, I would like to call also my teacher, the first speaker, retired but not tired, Professor Millicent Obajimi, for your donation, ma.
Yes, I am going to write my donation to the president. I'll give the president my donation. I'm going to send it to her in the private chat now. Thank you for calling me, for requesting. I'm going to send my donation now.
I see that with us online is the president of ICOMA Worldwide, Professor Emmanuel Otolorin. Thank you for being part of this program, sir. Please, sir, we are inviting you to make your donation to this cause. Professor Otolorin. Next, Professor Otolorin, please. The account details are displayed online, so you can begin to make your transfers. I would like to call the President or your M1, our chief host, Dr. Onyidamola Adeyemi.
Good afternoon, everyone.
Good afternoon, ma'am.
Good afternoon to my national president and the House. I would send the donation later.
Thank you very much, ma'am.
You're welcome.
Also present online is Dr. ZAINAB, the State President for M1 Kaduna. Please, ma'am, we would like you to make your donation.
Yes, thank you very much. I'm in the process of sending in our donation for this very noble and great cause. Thank you.
Thank you very much, ma'am. I will also want to call on the immediate past National President of M1, Dr. Oseji, to please make a donation.
Thank you. Of 20,000, and I have sent the acknowledgement to you via WhatsApp.
Thank you very much, ma'am. MWAN Oshun. I'm not sure if that is Dr. Bridget Omishore, but I know there's an MWAN Oshun. Please make your donation. Professor Olayinka Olasode. Professor Olayinka Olasode, also from MWAN Oshun. Yes, please make your donation, ma. Any representative from MWAN Abia? M1 Abia. M1 Adamawa. Okay, I just observed that the immediate past national coordinator, Dr. Agmonle, is also online with us this afternoon. Please make your donation, ma.
Good afternoon, all. National President, ma. Good afternoon, ma. I will make a donation of 10,000.
Thank you very much.
Oh, thank you. Well done, ma.
Okay. The national executives on behalf of National are making a donation of 100,000. M1 Abia, M1 Adamawa. M1 Lagos, M1 Ogun, M1 Ebonyi, M1 Enugu, Edo, Delta, M1 FCT. We are expecting your donations. Professor. Okay.
No, I want to do it.
Okay, Dr. Jennifer, M1 FCT. Please go ahead, ma.
Thank you, Madam MC. I want to congratulate the National President and the ESCO for organizing this. And it's a sad day in M1FCT. We just lost one doctor. And knowing how important how cancer is raging all over the nation, I think it's a very good initiative that medical women under the office of Dr. Otolorin has brought this on board. And we intend to ask for people to donate into it. This is seen as being shepherded by the Medical Women Association. Thank you very much.
Thank you very much, ma'am. I've noticed that Professor Otolorin is back online. Okay. I've been reliably informed that he has promised to make a donation. So the donations will continue. The account number remains on the on the screen. So please continue to send in your donations while we continue with the presentations. Thank you very much.
Thank you very much, the National Coordinator, Dr. Bemidara Mola, for getting that started. Again, I'd like to remind you that MWAN is very pertinent to do more. We are going to intentionally seek for funds for cancers, right from the chairman BOT to BOT members, that is Board of Trustees, to the National Advisory Committee of past national presidents, the NEC, the entire NEC, executive in the national and executive in the states, and all members. No amount is too small. We are going beyond M1 to all departments, to government, to our collaborators and donors and everybody. We need to raise funds. And when we have the town hall meeting with the NGOs, we are going to discuss the issue of funding, of programs, and of the needy. Thank you very much. We appreciate you. It continues. Thank you.
Thank you so much for your patience. We appreciate all our audience. Thank you so much. And our speakers, thank you for holding forth. Now we continue the lectures with Professor Alatise. Professor Olusegun Alatise, sir. He's a professor of surgery at the Faculty of Clinical Sciences, College of Health Sciences, Obafemi Awolowo University, and a consultant general surgeon at the teaching hospital. His area of interest is in surgical oncology and gastroenterology. He co-founded the African Research Group for Oncology in 2013. He is also a co-PI on multiple prospective studies on colorectal and breast cancer in Nigeria. He has trained several general surgeons across Nigeria. He has over 150 publications in peer-reviewed journals. Please let's welcome Professor Olusegun Alatise. Thank you.
Good afternoon, everybody. I hope I can be heard loud and clear.
Yes, we can hear you, sir, but not so loud.
Yes, we can hear you.
Thank you very much. And I want to especially thank the leadership of M1 for this invitation. Though I know Professor Isaac ADEWOLE has dropped off to attend another meeting, special appreciation to him for all the leadership role that he's been playing in cancer space. He's been a personal mentor to me and has been a facilitator to my growth in the academic routes. Professor Otolorin, we appreciate you. Professor Obajimi, we thank you for inviting me to give this talk, and every other dignitary that we have on this call. I'm supposed to give a talk on escalating breast cancer awareness, risk assessment, and screening. Initially, I thought I would be the first to give my talk before others, so I was planning to set a stage for others to give the talk. So I will do some repetition, but I'll try and skip over the repetition and focus on other things that I want to say. What's the current breast cancer narrative in Nigeria? As has been said, the incidence is rising. In the 80s, the incidence was said to be about 10 to 15 per 100,000. Currently, despite the not very accurate data we have, it has been shown that the incidence has risen to about 54 per 100,000 population. And we all know that because there are quite a number in the village and hinterland that were not captured in this database. So the incidence is increasing. In our database that we kept in African Research Group for Oncology, we observed that the number of cases that we see from our hospital is increasing in numbers. Unfortunately, as has been said, most of these patients present in advanced stage. Stage 3 to stage 4 account for 8 out of 10 of our cases, and majority of our patients have limited access to care. And we are not surprised because of the poor outcome. In our database that was published recently, about 2 years ago, it shows that 2 to 4 of the patients, of 10 breast cancer patients will be alive at the end of 5 years. Look at it, meaning that if we diagnose 10 cases of breast cancer, only 2 to 4 of them will be alive by the end of 5 years. What happened to the other 6 to 8? They died of the cancer. This is nothing compared, this is terrible when compared to what we have in high-income countries, where over 90% of these patients survive breast cancer. 2 things have been shown to reflect the, be shown to reduce the death rates from breast cancer. 1, it has been shown clearly that in a community where screening has been introduced, the number of deaths from breast cancer drops. And currently we now have a number of adjunctive therapy that can also assist in the management of this treatment, of this cancer, aside from surgery. So in a setting where they have effective adjunctive therapy that can easily be deployed to the community, as well as screening, the number of people that died from breast cancer drops significantly. And that's the reason why many of our women still die, because we are not catching them early using screening or any other early diagnosis strategy. And some of the adjunctive therapy that are supposed to be used, until recently, in fact, I remember in the early days, about 7-8 years ago, probably there was a year that there was no radiotherapy machine, functioning radiotherapy machine in Nigeria. Things is getting better, thanks to some of the efforts of Professor ADEWOLE when he became the Minister of Health, and some other initiatives that people have introduced. So all these adjunctive therapies are now available. I think the only headache we have now is cost. From our local data that was also recently published, it has been shown that if a patient presents early with stage 1 to stage 1, almost all of them will be alive at the end of 5 years. If you present at stage 2, over 75% of them will be alive at 5 years. But the curve begins to drop when they are presenting at stage 3, stage 4, of which, unfortunately, that's the stage where we see most of our patients. So what are the early detection strategies that have been introduced by WHO? WHO, World Health Organization, has defined 2 strategies to promote early detection of cancer. And this includes early diagnosis using identification of symptomatic cancer at an early stage, and also using screening. And screening essentially helps to identify asymptomatic disease in the target population of apparently healthy individuals. This cartoon helps us to put this in proper perspective. When you use screening, what you are hoping to do is to identify a group of patients that have abnormal cells or pre-invasive cancer, or invasive cancer that is yet to show its face. And then you identify them within the population, and then you send them for treatment. Of course, that also brings some ethical issue and some issue with screening, because there are some pre-invasive lesions that will never turn to cancer. But in a setting where you are using screening, they will be identified and they will be treated. So some patients are over-treated in the setting of screening. But it's better to over-treat a patient and save their life, because as of now, we are yet to identify what is the marker to identify those pre-invasive cancer that will never turn to cancer eventually. But when we talk about early diagnosis, what we are looking at invasive cancer that is already probably detected at 1 or 2 cm in the breast, and you can quickly deploy treatments to cure them. The only screening modality, as has been said by the eminent radiologists that are on the call, that has shown to improve survival and overall survival from breast cancer is mammography. Unfortunately, if you want to have an effective mammography program, it means that you have to have a means to recruit enough women in the target population to have a meaningful impact on the breast cancer burden. And that's an issue here. We have been involved in a number of screening programs, and even when a screening program is made available free of charge, I can say that confidently as regards FIT for colorectal cancer and colonoscopy. This screening program was made available for close to 400 women that were positive for stool-based tests. Only 60% of them come for screening colonoscopy. This is at no cost. Even their transportation was supposed to be reimbursed to them, but not all of them showed up. So if you are going to have an effective mammography program, you need to be able to catch as many of those women, either wherever they live, to come for that. So, and that's a challenge where transportation and security is a major issue in our setting. You need to have a facility to ensure high quality mammogram. You need to have enough radiologists who can properly interpret mammogram in a timely manner. The number of radiologists that we have in Nigeria as of today will not be enough to adequately be deployed to be interpreting only mammogram for 200,000 population, 200 million population that we have in this country. So that means we have a lot of challenge to roll out this program. You need to have a means of recontacting women that have suspicious lesion and ensure that they come for a diagnostic modalities for further evaluation. You need to be able to have adequate pathologists that are trained to be able to do the needful, and you need to have sufficient facility and personnel to provide timely and appropriate treatment modality. And I don't need to say, all of us know that in all these elements that I've mentioned, we have challenges in our setting. And aside from all those things, our populations are very young. We have short lifespan, where mammography may not even be appropriate modality to be deployed in such a population. Most of our cancers are identified at an early stage, where mammography may not even be the optimal screening modality in our environment. They are limited infrastructural and personal capability, they are competing health priority, and of course, as Professor Obajimi said, we have biological aggressive subtype, meaning that even between screening program, screening opportunity, you can still have interval cancers. And of course, we have low breast cancer incidence to justify massive deployment of resources. In United States of America, they draw up a model to identify how many women you need to screen to be able to reduce the breast cancer deaths. And they show that if you are screening a woman between the age of 39 to 49, to be able to identify women and save the life of a woman, you must have screened about 2,000. Unfortunately, that's the group of women that we tend to have in our population. Meaning that you have to spend money to screen over 2,000 women to be able to identify one. The number needed to be screened reduces as age increases. Unfortunately, at the age where the number becomes very relevant and meaningful, most of our women that will develop cancer will have already developed the breast cancer. And that's the challenge we have. And that's why many people, as Dr. Mishore said, many trials have looked at what works in our environment. And quite a number of people have recommended CPE as the first line of screening modality in Nigeria. The Mumbai trial by a group in Mumbai tried to look at over close to 80,000 women in cases and control, trying to assess screen them for disruption from somewhere. All right, okay. And they found that using simple screening modality like VIA, visual inspection, assessment of the service, and clinical breast examination may help to save a number of lives. So the summary is that there's limited evidence on what method of breast cancer screening that works in low-middle income countries, as Dr. Mishore has said. Mammography screening should be encouraged, as Professor Obajimi has said, when available and affordable. But unfortunately, availability and sometimes affordability become a challenge. So, clinical breast examination should be routine for all women in as client. What's the aim of early diagnosis strategy in Nigeria? The focus is on timely breast cancer diagnosis and treatment of symptomatic patients. And the aim is to achieve downward stage migration of this cancer. And to be able to achieve that, we need to continue to increase awareness. And I'm so happy MWAN is doing that. We need to continue to create awareness among our community. There must not be any week that there will not be an awareness program on breast cancer and other cancer on our social media platform and electronic and other form of communication media. And this must not be within the urban community. Those awareness programs must be taken as far as the rural community to be able to reduce life expectancy. So all of us must be an advocate. There must be a coordination of care through a referral network. We now know in the teaching hospital that not all the women that come with late disease are careless. Some of them meet with some health workers at some point in their career, in their care, and they were not notified on time. They need to act very quickly. So we need to train our patients. We need to train the community. We need to retrain the healthcare provider at all strata, be it the pharmacist that is prescribing drug in the pharmaceutical shop, including the nurses that are providing some health assistance in some of the rural sector, including community extension workers. Everybody needs to be scaled. We need to scale up our knowledge that this is a death sentence if it is not caught early, and the earlier we refer the patient, the better. There must be a timely access to breast evaluation, follow-up diagnostic access. We must have availability of an access to early diagnosis treatment. And to achieve that, there must be universal treatment coverage to ensure fund is not a delay. This is the algorithm by the WHO to guide how you can diagnose early. Number one is to empower and engage people, like I've said, at the community level, improve health literacy and reduce cancer stigma and facilitate access to primary care. So if you want to reduce the scourge of breast cancer in Nigeria, we cannot stay in the teaching, in the primary, in the secondary and the tertiary health sector. We have to also address this right from the primary health care. There must be proper improved provider capacity at first contact point, and we must strengthen our diagnostic and pathological services. We must do all we can to develop referral mechanism and integrated care, in which somebody that sees this patient in Igokoda, in the village in Igokoda, or in my village in Adekemi, will quickly notify somebody at the secondary or the tertiary health care about a patient that needed an assistant, and such treatment will be facilitated as soon as possible. There must be improved access to treatment by reducing financial, geographic, and logistical and socio-cultural barriers. At every mosque, at every church, at every religious gathering, we must encourage talk along this line, and that's the only way we can reduce the scourge of cancer in our environment. If you do an early detection strategy, one thing we can do is that it helps us to have clinical downstage of the cancer, and this has been shown by some paper that have been published previously. In those papers, it was shown that if you do all these three things that WHO has advocated, the downward trend of those cancers without even mammography, we will be able to downstage the cancer from stage 4 to stage 1, stage 2, at a stage where those cancers can be cured. And WHO has also published the data that if early diagnosis strategy is deployed at each community, the number of women that will die of the cancer drops significantly. I was thinking that I will give a prelude to the work that some of my junior colleagues have been doing in Ife. and I don't need to talk about it, looking at the role of CBE, the role of high BE in early diagnostics strategy, and the role of ultrasound in diagnosing breast cancer early in our community. This has been deployed and has been shown to be very effective. And of course, Dr. Mishore is leading a study on triple mobile assessment and patient navigating model. I believe this is going to be a model that we will need to deploy to every aspect of the country in the nearest future. And from the study they've shown, the initial data they have is showing that there is an impact in the survival of cancer that are seen in those communities that they are currently exploring. I won't end this study without talking about how do I assess myself for risk for developing cancer. And a paper was just published early this year looking at stepwise approach for risk breast cancer assessment. How do I stepwisely assess myself as a woman? What are the things I need to look at? And the first thing they recommended is that one should look at your family history. If any person, any individual, any woman or any man has developed breast cancer in your family, that shows that your risk of developing breast cancer is higher, and you should deploy a screening modality as soon as possible. So if the family's history is negative, then you can go to step 2. The unfortunate aspect in our community is that many people are very secretive about breast cancer. We need to break the hype about breast cancer, because people will not talk about breast cancer because they don't want to be ostracized, they don't want to be ridiculed, they don't want to be seen as developing cancer as a punishment from the devil or from God. So because of that, they are not releasing information. There are families that have seen that have managed the mother for breast cancer, but the daughter does not know that the mother actually had breast cancer. So we must educate our people that have breast cancer. If you keep the story, you are not protecting your family. The best way to protect other people from developing this cancer in your family is to share your information with your immediate family so that they know, and that can trigger them to be able to be watchful in looking at any signs around their breast. If there is no family history, then those things that need to be looked at is the age. Any woman above age 50, the incident or the risk of developing breast cancer increase from age 50 to multiple fold as the age increases. So as you age from 50 and above, if you have not developed breast cancer, praise God, but your risk, based on the age, your risk is, you are at a higher risk of developing cancer. So you must you must be watchful. Fortunately, we don't have there is none of our ethnic tribe or any tribe that is related to be peculiar to develop breast cancer, unlike what we have among the Ashkenazi Jew, where studies have shown that they tend to have higher incidence of breast-related cancer antigen mutation. So we don't have that in this environment. So ethnicity may not be a problem, but age is a major problem. Other things you need to look is the age at menarche. If you develop, if you start your menstruation before the age of 15, in those days, most of our mothers don't develop breast, they don't start their menses until age of 16, 18 and above. But these days we know that most of our children start their menses at the age of 11. So if there is early menarche and late menopause, your risk is likely going to be increased because your breast is exposed to it for longer time to estrogen, which is a mutagenic effect, which has a mutagenic effect on the breast. So when your menstrual period is prolonged, that shows that your risk of developing breast cancer is higher than others, that their own is not prolonged, and you need to be watchful. If your age at your first birth, and this is becoming a problem because almost every woman are professional now, you want to finish your university education and establish yourself before you go into marriage. If age at first live birth is over 35, the risk of developing breast cancer is higher in you, and that shows that you need to be watchful and adopt of any form of screening modality that works in our environment. If you have any reason to use exogenous hormone, either during fertility treatment or during treatment of menopause, your risk increases and you need to be watchful. Obesity is a risk factor, as has been said, and if you are obese, your chances of developing breast cancer is higher. And this is something you can calculate yourself. Just measure your height and weight and do your BMI. Your BMI is higher than 25. Your risk of developing breast cancer increases as the BMI increases. So you need to be watchful. Of course, in a setting where they do a routine mammography assessment, all the mammography report, all the breasts have been classified as either densely dense breast. I'm not a radiology, but I know my radiologists in the house know that using the mammograph, you can classify the breast as either dense or not dense. So those that have dense breast have high risk of developing breast cancer, and they should be sent for screening assessment, risk assessment as soon as possible. Also, you need to evaluate all forms of other risk factors like cigarette smoking, alcohol, as has been listed. If all those risk factors can be found in your personal life, your risk of developing breast cancer is higher, and you may need to adopt screening or any form of any detection strategy as soon as possible. There are free online models that you can just key in some of this, your data. There's SCI gain model, they are all free. These CSC tools and the IBIS trial tool, they are all available for any individual. Just slot in your data. It will classify you as either low risk of developing breast cancer, moderate risk of developing breast cancer, or if you have high risk of developing breast cancer. And I encourage every woman, every educated woman and not educated, and if you have a non-educated woman around you, to do it on behalf of your family and see what is their risk assessment. And if they are high risk, you can send them for. Those are the people that we should be sending for the few mammography machines that we have available. And I'm sure if we do that, we will not overwhelm the few number of radiologists that we have to provide service to over 200 million people that we have. So let me conclude by saying current breast cancer narrative in many Nigeria call for concern. It also provides a whole lot of opportunity for improvement. Much of this has not been explored, and I'm happy to say that some of my junior colleagues, Dr. Mishori, Dr. Olasende, they've taken the bull by the horn to continue to explore some of those early detection strategy in breast cancer, while I'm doing my own part in colorectal cancer. Kudos to you, and I encourage you to continue to do your best for the humanity. We need to have programs involving discipline across the entire breast cancer care continuum. We need to have programs along all breast cancer care continuum to be able to have huge potential for success. We need to continue to use available models as aid. There's a need to design and evaluate programs that fit into our socio-cultural and economic reality. So in conclusion, what I will say is that in Nigeria, to be able to reduce the scourge of cancer, we need to think globally and act locally. Thank you for listening. Special appreciation to some of my colleagues that actually helped in preparing this slide. Thank you.
Thank you so much. Thank you so much, Professor Alatise, for that very brilliant presentation. We appreciate it. Thank you so much. He has educated us on how we can actually do our risk assessment for breast cancer and also assess our patients before sending them off for mammogram. He has also told us the importance of early diagnosis and the fact that the 5-year survival rate is almost 100% for those that are diagnosed early at stage 1. So we appreciate you so much, sir. Next on the line is Dr. Well, I'm prophesying, is Dr. Olutosin Awolude, my own Oga here in UCH. He's a consultant, gynecologist, obstetrician. He's a senior lecturer here in UCH. He was a former director of Infectious Disease Institute of the College of Medicine, University College Hospital, Ibadan. His special interest is in the cancer of the cervix. Dr. Olutosin Awolude, please. Thank you so much. Let's appreciate him.
Thank you very much, Honorable Dr. Ilori. I appreciate that. Let me, I don't know, I think my cursor is busy again now. I don't know what is happening. Okay. Let me stand on the existing protocol, but I will be unfair to my teacher, my mentor, if I fail to recognize in that Prof. ADEWOLE, because anything I'll be saying here today, probably chunk of it was actually infused into my system by him. A lot of people have attested to his global leadership in encouraging the young ones. Thank you very much. And let me thank MWAN as well for inviting me to make this presentation, and to especially recognize a grandfather of ours in obstetrics and gynecology as well, our ECOMA president, Professor Otolorin. And thank you, Ma, for inviting me to give this talk. So let me run. I've been told that I have 10 minutes, and I will try as much as possible to say my own thoughts, concerning unraveling this burden of cervical cancer in our own setting. And I've titled my talk as Escalating Cervical Cancer Screening, Awareness and Uptake in Nigeria, Place of Resource Stratification Approach. I have no conflict of interest, nothing to disclose. Well, we've listened to a number of people who talked about cancer generally. And interestingly, today we are talking about reproductive cancers. And as we all are aware, breast is a reproductive organ, and so also is cervix. And just to let us know that this reproductive cancer consists about 25% of cancers in our own setting in low and middle income countries. And according to Geriatric and co-workers in 2013, for all women ages in rank order in Ibadan cancer registry, our own cancer registry here, the first three reproductive cancers are that of the breast, 40%, cervix, and then ovary distant third. So we can say that we are talking about the big two female cancers today. Well, cervical cancer in our setting is the most common gynecological cancer. And in 2020, all over the world, there were about 604,000 cases. And you can see that over 50% of such cases die within that year. But the interesting thing is that over 80% of these new cases and 85% of the deaths occur in our low and medium income countries. And if you look at the population of Nigeria, you can imagine the number that we are contributing. And in fact, at a point, Nigeria was one of the Afro 10 when it comes to cervical cancer in sub-Saharan Africa. And from this picture, you can see the darker the picture, the higher the body of cervical cancer. Yes, we might not have the darkest of the color here, but you can see we are not too far from the greatest body of cervical cancer. The greatest body is in Southeast Africa, but of course, if you look at our population in absolute number, the combination in Southeast Africa might just be at par with our own body in Nigeria. So cancer, cervical cancer is a great burden in Nigeria. Now looking at this, we can say that in 2020, we have about 12,000 new cases in Nigeria out of about 117,000. 117,000 in sub-Saharan Africa. And you can say that the number of deaths, over half of the cases in Nigeria died in that year. And our crude death rate was almost 78%. Well, looking at it in terms of number now again, we can say that cervix is still the greatest burden for gynecological cancer when you talk about genital cancers in Nigeria, and constituting about 67.7% from that global data. But look at our data from our registry in 2013 in a work led by myself and my colleague, my friend, my late colleague and friend, Dr. Okolo, of blessed memory. We saw that 80.5% of genital cancers in our cancer registry in Ibadan, out of about 5,113 cases, were that of cervical cancer. Whereas that is not enough in terms of mortality now, you can see why we have about 20,000 breast cancer cases in Nigeria and 12,000 cervical cancer cases. Look at the case fatality rate. That of cervical cancer is far higher than that of the breast cancer, only second to that of ovary. Of course, we all know that ovarian cancer is the most deadly gynecological cancer anywhere in the world, not only in Nigeria. So the message is that if you do nothing to arrest this situation, we are likely to be seeing about 135,000 new cases of cervical cancer and 83,000 deaths in Africa by 2030, and about 19,000 cases and death, and 19 new cases in Nigeria and 15,000 deaths in Nigeria by 2025. And what are the reasons for this high burden and usually poor access to effective screening and education of precancerous lesions? We can see how big our country is, and then we can actually pick the number of providing areas in our settings. And this is actually a lot of late presentation. Prof. Alatise just mentioned to us that when you see cases in the early stages, you can be sure that 100% of them will be alive in 5 years. But when you are getting to stages 3 and 4, at which over 75% of our cases present, you can be sure of what the case fatality or the survival will be at 5 years. Also, coupled with this is inadequate treatment services, including equipment as well as personnel, where I can tell you that things have improved over the years, but we are not there yet, and we still need a lot to do. Well, it's not all gloomy, because if we pay attention to this slide, that the good news is that we know what causes cervical cancer, human papillomavirus, especially the oncogenic variants. We have effective preventive vaccines. Globally, we have about 3 licensed by FDA now, but only about 2 available in Nigeria. And although some countries like China and India are already producing their own local vaccines. And where the other beautiful thing about this cancer is that we can detect the precancer stage using methods that can easily be practiced by every cadre of healthcare workers. When those precancerous lesions are detected, they can actually be effectively treated. And even the early cervical cancer cases can be cured through treatment in our setting. Like I said, human papillomavirus is the causative agent for over 95% of cervical cancer. But of course, the other thing is that it requires the persistence of this virus for it to actually cause cervical cancer. So in some literature, you see people calling cervical cancer as a rare consequence of human papillomavirus, and I will show this as we go on. Just to let us know that human papillomavirus is so ubiquitous, and then we have them all over the space, but of over 100 genotypes that are available. About 40 of them will affect the genital tract, and only about 14 or at most 15 of them are high risk enough to cause cancers, whereas others are low risk that can cause other diseases like the genital warts and some other skin lesions. The papillomavirus is, like I said, is a commensal of the skin and mucosa surfaces, and there are a lot of them actually grouped according to the disease condition that they cause. And you can see that the one that actually cause cervical cancer are to our right, as you see the screen and all those things. And a lot of them are like type 16, 18, 45, 31, 33, 45, 52, 58, and so on and so forth. Yes, for the natural history of the cancer, I will just run fast as much as possible. One thing I just want to say about this slide is that for human papillomavirus to infect any human being, it means that there have to be a kind of damage to the epithelial surface. And that is also one of the things that makes us understand the etiopathogenesis of cervical cancer from human papillomavirus. But the other thing is that it takes years of being infected with human papillomavirus or even developing the precancer lesions for one to develop cervical cancer. So the implication of this is that there are long years of window of opportunity for us to actually curtail the burden of this effect of this human papillomavirus. I've said that well, we have a lot of, about 14 of such human papillomavirus affecting the anogenital area to cause cancers. But other thing on this slide is that you should know that 16 and 18 are the most notorious of this human papillomavirus. These two alone, out of about the 14, will cause 70% of cervical cancer. And HPV is such an ubiquitous, a virus, like I've said, and is the most common sexually transmitted infection that it is said that 80% of women will be infected in their lifetime by this virus. But the good news is that over 90 to 95% of this will be cleared by such immunocompetent women, leaving only very few numbers with persistence of the virus to develop precancer lesions that, if not treated, will subsequently lead to cervical cancer. So this picture is just to tell us that all women are at risk of human papillomavirus as long as they are sexually active. And so for this, maybe 80% of women will be infected with the human papillomavirus. But you can see the number that will develop abnormal cells, cervical cells, having been infected with human papillomavirus, and that virus persists due to failure of the system to clear the virus. And even a smaller number depicted in red will develop cervical cancer. So that's why I said some people classify cervical cancer as a very rare consequence of human papillomavirus infection. So what are the risk factors for HPV infection and cervical cancer? Sexual activities is one of the main risk factors. Early coital care, that early sexual debut, is one of those risk factors. And multiple sexual partnering. I'm using the word partnering. That's the way I understand it. Because some people believe that when you say multiple sexual partner in a female, you're only talking about in a heterosexual setting, a man. But then you should also know that infection from another female sexual partner can be actually taken to another woman by the something. And even some women can even infect themselves, when they are involved in some aberrant sexual activities. Other risk factors as listed in this slide: low socioeconomic status, cigarette smoking, immunosuppression, and then exposure to cholesterol and all those stuff. But more recently, people are now talking about even a family history of cervical cancer, because some people believe that some families might have this genetic predisposition to not able to control HPV infection. As such, they are at risk of developing cervical cancer. These are some of the things that are coming up. Beyond these risk factors are some other factors. Competing problem on orthodox medical practitioners in our setting, and in a work by my team and also earlier by Anolu et al. In Lagos, show that even some of our patients present late because the system actually failed them. And from our work, we realized that a lot of them have been to have been to public or private health facility 3 to 5 times before the diagnosis of cervical cancer is made. And most of these cases, these diagnoses are made having been referred to tertiary health institution, having failed to respond to just antibiotic prescribed to them due to offensive vaginal discharge without adequate evaluation or examination of the genital area. Also, the lifetime risk of developing cervical cancer is also disproportionately against the Black population. whereas it is 1 in 176 among the whites, it is about 1 in 130 among we, the blacks. Like I said earlier on, apart from primary prevention, which is by education on some behavioral changes and then the biological method of vaccination, there are screening methods that have been shown to be effective for actually preventing cervical cancer through early identification of precancer lesions of the cervix. And broadly, I will classify that into those that are currently in use and those still at the experimental level. And those currently in use will also be further classified into 3 broad groups. Those that were based on visual inspection, that's where you have visual inspection after application of acetic acid or local iodine, or the cytological method like conventional cytology or liquid-based cytology, or the HPV testing like HPV DNA tests that are now upcoming in our setting. This slide just shows some strengths and limitations of these 3 broad groups, just to let us know from this side that HPV DNA is about the most sensitive of all the tests, but the specificity is not as fantastic compared with that of cytology. BIA has been shown in various studies to compare favorably with the cytology method, and WHO recommended that method to our low and middle income countries earlier. But with development of low-cost HPV tests and equipment now, HPV testing is becoming a common thing in some settings in low and middle income countries. In terms of performance, like I said, yes, sensitivity of HPV DNA test might be fantastic, but in terms of specificity, you can say that cytology has an edge. And this is an important concept to understand when we start talking about combining tests to actually maximize the effects or the outcome for our own setting. So depending on the method you are going to, that you decide to adopt, there is an algorithm developed by WHO in 2014. This is the algorithm for VIA test, that's visual inspection after application of acetic acid. And simply says that when you test a woman with 3 to 5% acetic acid and it is negative, you can actually ask that woman in a general population, of course, to come back in 3 to 5 years for the screening. But when it is positive, there are further things that you need to decide. For such women, you can decide to treat them the same day with ablative method if they are eligible. But if not, you actually need to determine the eligibility for LEAP, in which case you might have to refer or defer your treatment for another day, especially if you do not have LEAP facility at that setting. But even if you have LEAP facility, of course, people still believe that you may have to take biopsy to be sure that you are actually appropriately treating such a woman, because the aftermath of LEAP treatment can be more compared with thermal ablation. But if you have suspicious cases for cancer, then you have to refer for appropriate evaluation, diagnosis, and treatment. For cytology, this is actually more complex. This has been utilized in the developed world and has actually reduced their cervical cancer rate, but this has never worked in our own setting due to a lot of factors, mostly infrastructural and personnel. We have not been able to adequately actually accommodate cytological method in our setting because it's a more technical method, because you need to take the sample, you need to go and process it in the lab, it has to be read, and then you have to come back, and then it involves multiple visits to the clinic, then predisposing our patient to loss to follow-up and failure to complete the continuum of care needed for adequate control and prevention of cervical cancer. So this is the algorithm, and this is the algorithm for HPV tests. So depending on the method that your system can cope with, then you can actually, you have the appropriate algorithm to follow. However, for us, in some of the low and medium income country, we may just have to decide the appropriate method based on a number of factors. For me, I believe that availability of resources is one of the factors you need to consider. The personnel you have is a role. Then the characteristics of the population you want to screen, and even the available screening method or the treatment method is also key in determining the method you want to adopt. So, and The other factor that we need to consider is that what are those factors that actually make cervical cancer prevention through screening a success? 3 things that I consider, in my opinion. Availability of organized screening program is key. We need to have organized screening program as against opportunistic screening program. And you need to cover large population. You need high population coverage for it to be effective, to be successful. And then you need your patient to complete the continuum of care. That is, the loss to follow up is minimal as much as possible. So an organized program is more effective than an opportunity program, and most importantly, high population coverage is a necessary factor for success. So these are some of the things that you need to consider when setting up a cervical cancer screening program. And looking at global UMAR resource for health, and you can see Africa is disproportionately affected by low level of manpower, across the medical and the nursing cadre that have actually been the focus for some of this screening and treatment of precancer lesion of the cervix compared with Europe and America. And so I will try to look at what is our health workforce in Nigeria. From the literature that I searched, you could see that we have about 3.8 doctors per 10,000 inhabitants in Nigeria and about 15 nurses per 100,000. I'm sure this will be dropping per day as we are all aware of the attrition or emigration of our healthcare personnel in recent time. And in terms of rural-urban distribution, we can say that urban residents have about 3-fold greater access to doctors, 6-fold greater access to nurses and midwives compared with rural settings. I can even tell you, as you move to the lower level of healthcare, the level of doctors and nurses actually drop. And you can be shocked that even in Ibadan, within Ibadan, not local government, you need to visit the primary healthcare center, and you'll be sure that the only group of healthcare workers you can find there are the community health extension workers. I've thought about attrition of the healthcare personnel. And recently, I was part of the team that was looking at health personnel pattern in Nigeria. We realized that the greatest number, about 46.2% of our healthcare personnel in Nigeria these are community health extension workers. And only about 25% are nurses, and even the physicians are just about 6.1%. And in terms of where services are being provided in public health facilities, in health facilities, majority of services, our population are being served by primary public health facilities. So these are some of the things that we need to bring into context when we are developing a kind of screening program for a particular setting in Nigeria, in my own opinion. Yeah, this is the global target for elimination of cervical cancer by WHO. That is 90% of our young girls should be vaccinated with HPV vaccine before age of 15. 70% of women that are linked for screening should be screened, and about between the age of 35 years and 45 years. And 90% of those that are screened and need treatment should actually have adequate and effective treatment for us to talk about elimination of cervical cancer as targeted. And what is the WHO target? It says by the year 2000, there should be reversal of the burden of cervical cancer all over the world. Are we going to achieve this? For me, in my own opinion, I think one of the ways to achieve such is that we should look at our setting and approach our deployment of cervical cancer screening in a resource stratified manner. While HPV testing may be the most effective method for cervical cancer screening, different tests may be preferred in different localities, depending on the availability of resources. And WHO in 2014 actually gave this algorithm to help you to decide what you are going to do. And say, do you have a screening program in place? If your answer is yes or no, do you have enough resources to provide an HPV test? If your answer is yes, do you have a screening program in place? If your answer is yes, you do HPV test followed by VIA as a triage, because having HPV positivity does not mean that person have a disease on the cervix that needs to be treated. You still need another test to actually determine the disease. However, WHO also states because of the high pathogenic state of HPV 16 and 18, you can actually use ablative method to treat such patients because of the high risk of developing precancer lesion. But if you do not have a program in place, they want you to actually adopt HPV test alone. But if your answer is no to having resource to provide HPV test, they simply say that, please, you can go on with VIA alone, and it will still serve your purpose while you are mounting resources to develop HPV-based testing. But if your answer is yes to screening program in place and in cytology, then you need colposcopy services for it to be meaningful. If you do not have colposcopy services, then you can go to the HPV site again. But if you have, then you can have your cytology or HPV test followed by colposcopy, and you follow the treatment algorithm as stipulated. So because people believe that resources are not equally distributed, ASCO, that's American Society of Clinical Oncologists, in 2016 actually came with this resource stratified clinical practice guideline. And in this, they recognize 4 levels of service: basic, limited, enhanced, and maximal. And they actually define what this level means, and then based on that, they recommended. In their own recommendation, HPV DNA testing is still the recommended screening test, the priority screening test. However, if this is not available, visual inspection with acetic acid may be used in basic setting. And then they thought about recommended age range and when to exit the screening. And if you are going to use HPV-based screening, what should be your triage mechanism? And after treatment, what should be your follow-up? And these are well documented for countries to actually domesticate to suit their own setting. Well, just let me share my experience from a little what we did at Ibadan Central, that's Ibora, in 2016, through a small support from ASCO, in which case we actually, as a as part of our experience from our HIV program in that setting, we realized that of all the primary care centers in Ibora specifically, there were no nurses in any of those primary care centers. Yet they provide family planning services, they take deliveries and all those stuff. So we came with a small concept that if these people have been so skilled to do this, can't we just add them to recognize normal service and then identify abnormal service? For those that have abnormal services, they should just send them to general hospital where they have nurses and a medical officer. And at the end of the whole process, we compare their screening, a process with those of the nurses in Ibora. And then using CAPA's system, we realized that there was no there's no difference between their performance.
Can you hear us?
Yes, ma'am.
Dr. Awolude, please,
yes,
because we have 2 other speakers, can you round up in 3 minutes?
I will round up in a few minutes now.
Thank you.
So we just realized that performance of CHU and CHOs can actually be effective in controlling cervical cancer in settings whereby that's the only healthcare workers that's in those settings. Even when you want to develop a HPV-based setting, you can still do that in hard-to-reach area by combining mHealth with your, with your platform. And these are all available for you to use, in which case somebody in the remote area using smartphone, if they have any doubts, they can actually send pictures to an expert in the city who will then advise them real time, and based on that, they can actually provide cervical cancer screening. So based on this thought, I actually came up with this, algorithm, especially with the coming of point of care HPV testing machines that are now available in our setting. So I will conclude by saying that cervical cancer screening strategy organization is important for maximal benefit and cost effectiveness, while resources availability might limit development of the most sensitive screening method, which is HPV-based. Adaptation of available health strategy like telecolposcopy and maximize utilization of HPV-based screening strategies in the era of emerging low-cost and LMIC-friendly point-of-care testing. And in the alternative, we will recommend resource stratify for different settings, even within the same country. Thank you for listening.
Thank you so much, sir. Thank you so much. It's not difficult to know a man that is passionate about his calling. He has ignored all warnings to stop. He had to deliver the message. And I hope we all got the message that cervical cancer has a very high fatality rate, and that its prevention is better than cure. We now have HPV vaccine, and I think very soon it will be on the national immunization schedule. So we should encourage our mothers to take the vaccine, to take their children for the vaccine. Thank you once again. Please let's appreciate Dr. Awolude. Thank you, sir.
Okay, so moving forward, we would like to call the next speaker, Dr. Omolade Betiku. I hope you're on the call, ma'am. Okay, Dr. Omolade Betiku is a histopathologist with special interest in gastrointestinal hepatology and breast pathology. She's passionate about the standardization of histopathology practice in Nigeria, helping to train medical students and resident doctors in this regard. She also wants to influence junior and senior colleagues in such standard practice for the benefit of individuals suffering from cancer. She's open to developing and expanding diagnostic skills, abilities, and novel research. She's currently employed as a consultant pathologist with the Obafemi Awolowo University Hospital Complex, Ile-Ife, Osun State. Please, can we have Dr. Omolade Betiku start our presentation? Thank you.
All right. Good afternoon, everyone. I believe you can see my screen.
Yes, yes.
Hello?
Yes,
Okay.
we can. Thank you.
Yes. The topic before me this afternoon is to show the roles of pathology in breast cancer diagnosis and treatment in the molecular era. First of all, I thank the organizer for inviting me to give this talk. And I appreciate it. And I also want to appreciate everyone on this call for being able to listen to me. All right. And when I was preparing this, while I was preparing for this lecture, I was looking at what has been the thing that have been ongoing in research as to molecular diagnosis, helping to diagnose early cancer and helping to make a diagnosis that can influence treatment. I came across this paper that developed multimodal cell phone-based platform, the EpiView D4. This they are meant to evaluate both the cellular. This EpiView D4 is for evaluation of the cellular morphology and molecular expression of clinical relevant biomarker that can directly that they use fine needle aspiration to do it. And this particular research can be done in just 1 hour to be able to diagnose, to find out what are the molecular expression of breast, just by the way of introduction. That means that research has really gone far into the molecular diagnosis of breast cancer, in making a quick diagnosis, in prognosticating, and also in treatment, also, and even follow-up. By the way of introduction, pathologists play a critical role in characterizing and reporting molecular biomarker that inform management in breast cancer. And this role that they play basically is to be able to, apart from making diagnosis, to be able to prognosticate, tell us the outcome, also to predict response to therapy. And this biomarker provides vital histopathological evidence and this play a major role in determining prognosis. Some of these parameters are part of the minimum data set requirement that we use in diagnosis of cancer. Please, there's something including my view, so let me drag it. All right. So breast cancer, as we all know, is an heterogeneous disease, especially when you talk about at molecular level. And with the introduction of high throughput technology, the diagnosis of prognostication therapy, it makes it easy for us to subtype the breast cancer as well as to also prognosticate. There are also other existing factors and approach that have been used in making diagnosis or even or prognosticating, or as well as monitoring treatment, which includes single disseminating tumor cells, circulating tumor cells, either in blood, urine, or even in bone marrow, as well as circulating cell-free DNA microRNA, which can be used even after surgery to monitor if patient is responding to therapy or not. Before the era of molecular diagnosis, what we've been using something, and those are the traditional prognostic as well as predictive factors, which include histological type, the maybe is it lobular or is it the NOS, that's the non-special type, special types, that medullary carcinoma, metaplastic carcinoma, and the rest, and the tumor size as well. The bigger the tumor is, the worse the prognosis most times. The histological grade, the high grade are worse. The surgical margins, as a pathologist, our surgeons are usually interested in the margins to know if they have done an adequate surgery. There are also other traditional markers that we use, like the mitotic index. That's how much of mitosis is in when we look at it histologically now. Then the lymphovascular invasion, is there any invasion into the, is there any muscle, malignant invasion into vessels, which we have in metastasis. Also skin involvement and nipple involvement. These are the information that we give to our surgeons when they send sample to us. So in the biomarkers that are being used in pathologies actually been broadly classified into two basic ones. The one that have been established, for example, the hormone receptor and the L2 status. And the emerging ones, like the key 67, which is a marker of proliferation. And although in this one, the cutoff point, there has not been a standard cutoff point for key 67 marker. There's also P53, which the is a tumor suppressor gene that when a tumor express it, it shows a high grade, even though we know that most tumors have this mutation. Then cyclin E, there are also some multi-gene signatures that have been developed and some parameters which we'll be seeing, discussing in detail as we go on in this lecture. Then there's circulating tumor cells, circulating cell-free DNA or microRNA. Also, there's this tumor-infiltrating lymphocyte, which is gaining popularity as regards to especially metaplastic carcinoma. And this is immunotherapy that have developed. The program dead cell ligand PDL1 is also one of the things that is being researched. All these other ones have not been used in routine management of a patient, but it's all under research. So, when what are the requirements? What is the required optimal specimen that a pathologist will use to make a diagnosis, either for the if you want to use a molecular, use a molecular diagnosis, For example, the fine needle aspirated cytology, just using a simple needle and drawing few cells. You can do a lot of things with it. Biopsy can be small needle biopsy or excision biopsy. Also, mastectomy. Eventually, when the diagnosis is being made, the surgeon, if the patient qualifies for mastectomy, will send the mastectomy to us, and we have to assess all this. Why will I say this? That because some of these specimens that we receive, they must be kept in an optimal status, so that if you want to do a further testing, you'll be able to have it in a good status. So when a specimen is sent to us, when it gets to the lab, we give it a proper number, so that sometimes we may need to retrieve it so that it will be easy for us to do. And it's usually kept in a fixation right from the surgeon, or even if it's not kept in a fixation, they must maintain the ischemic time. When they bring it to the lab, and we process it immediately. Then we do grossing, appropriate grossing, because some lesion, if you miss it at grossing, you may not be able to make an appropriate diagnosis and improve care of the patient before we send it to the lab for processing, depending on which one, whether molecular testing or even just histology, like the hematoxylin and eosin staining, or immunohistochemistry, which is the major one that we use as a surrogate molecular breast classification. That's what we use presently. How far is this thing gone, the molecular era of breast cancer? Over 2 decades ago, the human genomic have paved ways for omic revolution, which outperform the traditional biomarkers. And these are the genomics or the proteomics. These genomics have helped in gene expression, gene profiling, so that you'll be able to measure some of these mRNA transcript using DNA, microRNA. And so the result of this expression profiling study indicated the existence of number of molecular distinct neoplastic disorders. That means by profiling some of these, the characteristics of these tumor genes, we are able to classify some neoplastic disorder into distinct molecular classification, which will be seen as we go on. So what are these molecular subtypes that they are using genomics? What are they? One, the luminant A, luminant B, and also there's this A2 molecular type, and the triple negative breast cancer, which is also called the basal-like type, and there's also the non-basal-like type. In the luminant A, the hormone profile, the ER and the PR are positive, while the A2 status, A2 expression or overexpression of the A2 in luminant A, and also it's seen that the Ki67 is less than 14% in this group, while the luminant B, it's triple positive, and as we can see on the screen, that I will not bore you. Then for the molecular subtypes, they are also the morphological, to relate it to the morphological types. The luminant A is said to have more of the luminant A are tubular carcinoma, micropapillary carcinoma, mucinous carcinoma, and the endocrine types. For the basal-like, which fall into the triple negative, basically they are usually medullary carcinoma and even adenosquamous carcinoma, even metaplastic carcinoma. For the non-basal, we have the apocrine carcinoma. So with the help of molecular subtype, we are able to group some of these traditional histological morphology to classify them better. So people that don't have, maybe if people cannot afford to do some of these things, looking at the morphology subtype, they can be able to say that, okay, most likely this is the molecular subtype that the breast belong to. So for the triple negative, it's further subtype, still using gene expression profile into five or six, depending on the type. For the Lemma et al. Lemma et al. Classify it into 6, while the C-type 4 classify into 4 types, and the Boston et al. Classify into 4 types. And these types we are able to do that because of the molecular gene expression of this breast cancer. So going further, for the molecular subtypes, we've also known that there are some specific clinical characteristics that have been associated.
Yes. We have a few minutes more to round up, please. Thank you.
Okay.
So much. We still have another presenter.
All right, that have been associated with the subtypes. For example, the Luna A-like type, they are very indolent, they have low grade, and most of them respond to chemotherapy. While the Luna B, they are usually falling between the moderate and severe grade, and usually commonly metastasized to bone. And they also they can benefit from hormonal therapy as well as chemotherapy. Same thing with Luminant B-like. So these are the characteristics. But here, the two positive ones usually affect the younger age group patient, and they are usually of high grade. Okay. Also, using the molecular profile, we'll be able to use some gene signature to be able to classify that into so that they can prognosticate some of these cancer. This signature outperform all the traditional pathological or clinical prognostic factor. The mama print, it has been approved by the FDA for clinical use. Is the one that they are approved for clinical use. All other ones, you have a number of genes that have been assessed so that it's just for prognostication and also to be able to properly classify and also individualize treatment in each of them. So what are the challenges that we have in molecular diagnosis? Of course, everybody has talked about it. Talk of infrastructure, equipment, reagents. For example, if you have to buy a vial of two antibody, costs millions, and personnel to even look at it to make appropriate conclusion on them may be difficult. So we need some to overcome some of these challenges. We need to collaborate, and we need to apply for grants so that we can have money to be able to do them. And also government policy also can help. So instruct and also training of pathologists is required for to sustain the improvement of molecular diagnosis in breast. So in conclusion, the molecular tests such as the receptor status and the gene expression profiling actually complement the traditional histological biomarkers that we have. And what does it do? The main aim is to be able to estimate the risk of future metastasis or recurrence, to predict the likely response to treatment, and also to improve the stratification of patients with respect to outcome. And I must say here that the level we have is this surrogate molecular breast classification, which is still based on immunohistochemical assessment of our biomarker. So in our center, we do the hormonal profile, the estrogen, the progesterone, and the two status. That's what we are able to do here. And it has also helped our surgeon, apart from doing the normal traditional assessment histologically. so they can place the patient and so that they will know what the patient can benefit from, and they will treat the patient appropriately. Thank you for listening to me. These are my references.
A round of applause for Dr. Awolude Betiku. Thank you so much. At least in your presentation, you made us to realize that a lot has been done at the molecular level, and that at this point in time, molecular level can be used to prognosticate for predicting the likely response to treatment and also improve stratification of patients. Thank you so much. Please let us pen down our questions while the last but not the least speaker is introduced. Okay, and please, we just have about 10 minutes for this presentation. So I'll be calling the last but not the least. Yes, Dr. Elizabeth Ayoluwa. She is a consultant radiologist and associate lecturer at the Department of Radiology, University College Hospital, Ibadan. A fellow of the Faculty of Radiology, National Postgraduate College of Nigeria. She's a two-time award winner of Sonia Sholuga Prize for the Best Part 2 candidate in clinical radiology. She's a member of a lot of professional bodies, and she's passionate about breast imaging and interventional radiology. Please welcome with me Dr. Ayoluwa Elizabeth Idowu to speak. Thank you.
I'm glad to be part of this presentation, the educating women, taking our health with our own hands and making sure that we are doing the best for ourselves, especially in this time and age where things have gone haywire. I thank MWAN for inviting me, and I thank my mentor, Professor Obajimi, for the privilege given to me to make a talk this afternoon on breast examinations. As we are aware from previous presenters, what they have said, in this, our own society, we are less developed, and we still rely on breast examination to detect breast cancer, even though we know that it's not a screening tool, but it's better than nothing. So we'll go ahead into it. So we've heard breast cancer is one of the leading cancers in women, and that its early diagnosis and treatment is the key to improved prognosis with a 5-year survival rate up to 99% that Professor Alatise just told us. So breast examination include a breast self-examination and also clinical breast examination. What is it? It is actually physical examining your breast by yourself to detect if there are any abnormalities. When is it done? It's actually supposed to be done at least once in a month. It can be done, more than once, but it's recommended that it's done at least once in a month, 3 to 5 days after the period ends in a premenopausal woman. If a woman has stopped menstruating, she should pick a day, of the month, and it should be we usually advise to pick your birthday. For example, if you are born on maybe 3rd of July, you can pick 3rd of every month. Set an alarm that will ring off or remind you every 3rd of the month to do your breast examination, because you have to be consistent with the timing. And if you're a breastfeeding mother, it is advised that you empty your breast before you go ahead to do this breast examination. So usually, because we do this right after menstruation, some days after menstruation, because during menses, the woman's breast becomes lumpier, nodular, and sometimes tender. And so by that period, they are less nodular and tender. And when do you start? We recommend age 20 for every woman to start examining her breast. However, we've seen some less than 20 having some breast lesion, especially in my practice. I've seen juvenile lesions. So usually we say late teens or early 20s, but age 20 is actually the recommended age to start breast examination. So what are the advantages? Because it is non-invasive, it is simple, it takes only a few minutes for you to do, and it allows every woman to control her own health, and it provides you the knowledge of how your breast tissue feels like. So if you do it constantly, you know how your breast feels like. So, and then it can detect breast cancer at an earlier stage than if a woman does not perform breast self-examination at all. Well, the disadvantages is just that you can, have fear and anxiety about what you may found during the examination, like for the next month, like, oh, I hope I'm not going to find something in my breast. And it could also be, you can also have false positive, that like you feel that you have a lump inside it, whereas it's not a lump because you have not actually known how your breast feels like. So what's the, how do we do it, the technique? So the first thing is visual examination. You look, that's the first thing. And when you look at different angles. The first one, you put your arms by your side, you look at the mirror, you are making sure that your breasts are symmetrical in size, in shape, the color of the skin, the nipples, you are looking at the two. Are they the same? You look at the side, you raise your hands up, you look at the side, and as you raise your hand up, your breasts are supposed to rise as you raise your hands up. So you look at them, that at the breast also rising together with your hand, and you should check for any other thing, nipple discharge, any dimpling. Then you should also, the last one is to put your hands on your hips and lean a little forward. Your breast will come out, and then if there are any changes which were not obvious in the other positioning, they can also be seen in that way. So there are danger signs to look out for. Like I said, nipple discharge, dimpling of the skin, lumps, then obvious breast swelling, redness, and there's something that we also call peau d'orange, that is, it has like an orange peel appearance. There's this educative material. I got it from Know Your Lemon. It's actually a very good material that every woman should go there and sign up. It's actually an app. It's developed by an associate professor in designing. She started this after losing her mom, her grandmother, two of her grandmothers to breast cancer, and also her own friend, a very close friend, at age of 28 to breast cancer. So she was just looking at ways to educate women, and then she came about lemon. Lemon means that it has a nipple. The lemon has a nipple, and also the inside of the lemon also has the architecture of breast anatomy. So, and then this also to cut across cultural taboos around breast, that you cannot expose human breast, but she used this so that she can educate women on signs, danger signs of breast cancer. So whether you have a feeling of a thick area, dimpling, nipple crossed, redness, or that the breast feels hot, a new fluid, skin sores, bump, all these are on the app, and then it has the opportunity for you to log in your details. They can give you reminders, and then some other things, risk assessment. There's a lot of stuff on the apps which I will encourage women to visit, and then this will also help you, show you how you can actually do, there's a video on it that can help you to do the breast self-examination. So the second step is palpation. That's you feel after looking. You can either stay standing, but preferably you should lie down. And when you lie down, actually there are three different types, the three patterns of palpation. You have the line, which is also known as the grid pattern. You have the wedge or the pie pattern, which some people also call the clock pattern. And then you now have the circular or the swirl pattern. So you can pick any of this pattern, but you should stick to one so that you will actually have a consistent way of checking your breast. And then when you lie down, you fold a towel just right below the shoulder of the breast you are starting with. And then you place your arm at an angle. Then you put that arm under your head. So the opposite hand, for example, if you are examining your right breast, your left hand is going to be the one you examine that breast with. So there's this, it's an art. It's not just you using your hand. You must use the 3 middle fingers of your hand. So the second, the third, and the fourth, the 3 middle fingers, and then it must be the pad of your fingers, and your fingers must be straight. They must not be angled, so that you can have the right, the technique must be right, so that you can have an adequate, a proper examination, a proper check of your breast, and your fingers must move down and in circular motion, like 3 coin side motion. And then you are not lifting off your hand from the breast. So you move your hand, either any pattern you want to take, you want to use the clock pattern, whether it's a circular pattern, you move your hand and it should not be lifted off your skin without missing a spot. You check from, and using 3 graded pressure from light to medium to deep, checking the thickness of your breast. So once you do this, you move on to, these are just pictures of how a woman can examine herself. You know, lying down, putting a pillow under the shoulder, and then putting your hand at an angle. And then with the other arm, with your fingers, you palpate and then check for all the signs that I talked about: lump, swelling, whether there's any nipple. And then you must be sure that you press the nipple gently too, and check your axilla, your armpit. Because sometimes some women can just present with lumps in their armpit without anything found in the breast. So you must check everywhere and be sure that nothing abnormal is found there. The third thing, which is the third step, is actually for you to report any changes you have seen to a doctor as soon as possible. That's the third step. So whether you have any concern while you are doing it, maybe it's your first time, you think you might have had some issues with anything, you need to report to the doctor. That's the next step to take. So the clinical breast examination now is basically the same thing, but however, this is done by an healthcare professional. And usually when you visit the healthcare professional, sometimes you might have missed some lesions. The healthcare professional can pick this up while while he or she is doing the examination. So usually part of routine annual checkups for women between 20 and 40 years, and also can be done when a patient presents with complaints, of pain or any noticed changes in the breast. What are the advantages and the disadvantages? Is like we have heard from our previous speakers, like it's an early a tool that can be used, to detect diseases early. It can also allay your anxiety. Sometimes when you check your breast, you feel that, oh, maybe you found something. When a doctor checks and says, oh, there's nothing, it's just your breast tissue, that this is how it feels like. So it can also facilitate your discussion of personal details, your risk assessment. Your doctor can also use that opportunity to do that. Then your doctor can teach you how to properly carry out a breast examination, and for you to recognize normality. And like I said, it's better than nothing, especially in this our region where we don't have easy access to screening materials easily. So, and then disadvantage is that it can be a false reassurance, because sometimes some breast lesions might not be palpable. You might not be able to detect, you might not be able to know if there is anything going on. So it might have been a false reassurance from the doctor. And it can also cause anxiety. You want to go and visit your doctor, you are anxious, you don't know what is going to happen. Then it can also result, false positive or false negative, whether the lesion is there or not. And some women, because of cultural reasons, and religious reasons they don't like it, as you have heard, and even from practice, women don't like their breasts to be exposed, especially if it's a male doctor. They feel that they are invading their privacy and they find it uncomfortable, and it is actually time consuming for the doctor, because it is not just the examination that the doctor is going to do, because he's also going to do other things, and chaperone too may also be needed. You can imagine if you want to do breast examination, you are calling 1 or 2 people to come and stay with you, where you are wasting human resources, just for you to check breast examination. So the technique, it starts from history taking. So your doctor will take your history, careful history taking. He will take note of your risk factors and changes that you have mentioned to your doctor. And the next steps are actually what we have talked about, the visual inspection and then the palpation. You can sit or stand while the doctor is sitting opposite you, and the doctor also looks at the breast at various angles, like what we have actually talked about. Then palpation, the same way the doctor palpates the breast of the patient, and the outcome, the doctor is going to document the outcome and making sure that all that was noticed in the procedure is being delivered to the patient, and the next necessary step for the woman to carry on with, whether a woman is going to need further screening tests, like what you have been told, mammogram, a breast ultrasound, or an MRI. So based on your age, your risk assessment, or whether there has been any previous positive family history of breast cancer, will determine the further screening test that your doctor is going to recommend. He can also recommend a biopsy if it's needed. So these are the recommendations. Though breast examination is important in early detection and treatment, like we have known, but there's still somewhat a lot of controversy on it. Many developed countries, they no longer recommend breast examination for cancer detection, but they are actually very, they are recommended in less developed countries like ours, because we don't have easy access to healthcare, and so we basically depend on this. And it's been shown that about 40% of diagnosed breast cancers are detected by women who felt lump in their breast. So it is not a screening tool, yes, we know, but it is a very powerful tool which can be used in the event of no easy access to healthcare facility. So it is recommended that clinical breast examination be done every 3 years for women who are aged 20 to 40, and every year after the age of 40. So you must develop the habit of going to your doctor, and making sure that he checks your breast, even doing your own monthly, but you still have to go to your doctor every year if you're over 40, or if you are less than 40, 3 years you go to your doctor, and your doctor checks your breast for you. So in conclusion, early detection decreases breast cancer mortality. And a huge part of being able to detect breast cancer early is through a self-breast examination. Breast examinations are very useful tool in early detection, especially in underdeveloped and low to middle income countries that don't have ready access to other screening methods. What are the take-home points? If you have noticed, the breast self-examination and clinical breast examination, they have a rule of 3. Even their acronyms is 3. So I want to give you a brain teaser. There are so many things that we've talked about, 3, for you to remember, for you to think about these things. Like, okay, it has to be done 3 days after menses. It involves 3 steps: 3 examining fingers, 3 examining pattern, 3 coincide circles in 3 graded compressions. Please think about these things and make sure that you make breast self-examination a lifetime habit. It could be the best time investment of your lifetime. Thank you very much for your attention.
A round of applause for Dr. Ayola Oluwai Elizabeth Idowu for a brilliant presentation. And to summarize basically what she has said, she talked about the rule of 3. You do the self-breast examination 3 days after your menses, use 3 fingers, cyclical method, and so on and so forth. Thank you so much for that brilliant presentation. So right now, I think we will entertain questions from our audience, and it's quite impressive that we still have about over 50 people online. Thank you for your patience. So question and answer, you can either do that by the raise of hand or you pen down your question. Thank you.
I think there's a question for me from Professor Sokundu. Maybe I can quickly, while others are thinking of questions, maybe I can take that.
Go ahead, sir.
Yeah, thank you. Thank you, Mark, for your presentation, and thank you for your comments and encouragement. Yes, if you look at a lot of our, data, practically all our data, there's no national data on the prevalence or the number of our young girls that have been vaccinated. And even if you look at evaluation documents like from WHO and some other world bodies, usually they will say no data in some way. So I think the oncoming rollout of HPV vaccination in Nigeria will avail us the opportunity of actually documenting some of these things. But there are some studies here and there, probably based on their own survey, they've documented, like in their own population or people they studied, like a prevalence of about 6% or 14% of the studied population to have had vaccination at one time or the other in their life. Thank you very much.
Thank you very much, sir. Dr. Idowu, my question is, please, I want to confirm, I think I read it somewhere that by the time one is palpating a lump in the breast, and if the lump is actually malignant, that by the time one is palpating a lump, that it's like stage 2 or 3, and that the survivor rate may not be too impressive. I just want to help clarify that notion. Thank you.
Okay, thank you, Ma. Well, yes, it is true. Like we heard, mammogram has a way of, is actually the best screening tool for before a lesion is palpated, mammogram picks it. So once a lesion is being palpated, yes, it has, it has reached a stage. Not that we're saying that once you pick something, there is treatment. So it's better to pick it early than when it gets to a very late stage, whereby treatment will be more expensive. So if it's picked early, the treatment will also be early, and the cost of treatment won't be as much as when it is picked later on. Thank you.
Okay, Dr. Fumi Adenipekun is raising her hand. I think he's a female. Please, can you ask your question, ma'am?
Good afternoon. I hope you can hear me.
We can. Go ahead, please.
Okay, sorry, I'm not a doctor. I'm just a friend of the house. I was invited by one of your members. So I just want to make a comment and a question. Thank you so much for organizing this. I'm a mother. I have 3 daughters. So anything that has to do with female, I'm always interested. So for HPV vaccine, I was fortunate to learn about it, and I gave it to my first daughter. And getting for this myself, I usually give it to them when they are at 13, age 13. So getting the second one now was very expensive, and the second dose, I got to know that there's going to be a free one being organized. But my challenge is, I'm not sure which one we are going to get, because I know there are different variants. There's one that you can, okay, I'm not a doctor, so don't let me say what I don't know. I think they said there's one that is 2 doses and 3 doses. But because she has taken a first dose, I don't know if I should take her for this free one, or we should just continue with the clinic where we took the first one from. So that's my question. Thank you so much.
Okay. Thank you very much. I think Dr. Awolude should be able to address that question. Dr. Awolude, sir.
Well, it's a bit challenging, and I think you really need to find out which actually of the available two types your daughter actually took. It's either the two variant, bivalent one, which is the made by GSK, Cervarix, or the quadrivalent Gardasil. Honestly, I can tell you I'm not even too sure which one the Nigerian government is actually deploying, either Cervarix or Gardasil. But one thing that I think President of Nigeria Cancer Society is making a comment. The HPV vaccine variant, the national rule is Gardasil 4, and it's a one of those. Oh, okay. So I think the first thing you need to do is to find out the type that your daughter had actually, and from there you can take it. From most literature, they do seem not to encourage interchanging the two available vaccines, and I think that has to do with what is used to preserve the vaccine. So I think you need to find out.
All right, thank you, sir. I think what we got was Gardasil.
If it's Gardasil, then I think, like the president of the Cancer Society just said, is Gardasil has been being rolled out, so I think your daughter will be able to, access that. But I think, I don't know, my president, are we going for 1 dose or 2 dose regimen? Thank you.
Okay, hello, sir. Good evening. Actually, the national rollout is 1 dose because the intention is to cover as many girl child as possible. Currently, Nigeria has about 8 million doses, and these 8 million doses is what they will use to roll out in the 16 phase 1 states. Phase 2 will start around November, December this year, and it will cover the other states. Boys too will be included, but not now, until in the next 4 or 5 years. Nigeria is making efforts to get as many doses as possible as it stands.
Thank you.
Thank you, sir.
Thank you, sir. Please, sir, can you just reiterate the age range for this Gardasil?
Okay, it's 9 to 14 years of age. You know, according to WHO, it's 9 to 15. But probably because of the paucity of vaccines available, and the age range is reduced from 9 to 15 to 9 to 14, as it is.
Okay, sir. A follow-up to that question.
Okay.
Sorry, somebody also said that, is it possible for those who miss the HPV vaccine in the recommended ages to still get it? And they are sexually active?
Yes, definitely. The idea behind the vaccine is that it should be given before exposure to sexual intercourse. So it is believed that even if a girl is 18, 19, they can still get it. Even adults are encouraged to get it, up to 25 years of age, I think. The professionals may know that better.
Yeah, I think, yes, there's what we call catch-up age, that's 15 to 26, that those that miss the 9 to 14 years can actually take. Usually, the doses will be not 1 dose like the rollout. The immune response will not be as good as those between 9 and 14. However, my own recommendation usually is that because you see some women that have even had kids and all those stuff, maybe they can take the vaccine. Generally speaking, anybody can take the vaccine. It's for prevention. But if you look at the economy of it, maybe it's not a wise thing to go for the vaccine, whereas the screening will be what will be recommended for that age group. And screening is cheaper. And the only thing is that you should remember, like I said, it's a preventive vaccine. That does not mean somebody has been exposed to the HPV and is persistent taking the vaccine might not necessarily remove that. It can only prevent subsequent infection. So if that HPV that has been exposed to is persistent, that person is at risk of cervical lesion, even having taken the vaccine. So for me, let us do what is, cost effective for somebody that is sexually active. Screening is there and it's available and even cheaper than even the vaccine. Because I don't know adults who are not eligible to that free vaccine that the government is going to deploy.
Thank you very much, sir. We've actually have a very robust day. Right now, I'm going to give the mic to Professor Ike Ajayi, who is the MWAN National CME Chair and also the Director of MWAT, to do a closing remark. Thank you.
Thank you very much. Wow, it's been a very long and rewarding day for all of us. I want to thank our ladies, gentlemen, Mars and Sas that have been with us since the beginning of this webinar at 1 o'clock. I'm sure you will agree with me that it's been worth our while to have been part of this webinar. I would want to recognize our global icon on cervical cancer control, Professor ADEWOLE, who is the chairman of this webinar. And I recognize the president of the Cancer Society of Nigeria, Dr. UMAR, and all our professionals, doctors, nurses, all in the health professionals that have been on this webinar. I recognize all of you. Now we've come to the end of the webinar, no doubt, but we have had stimulating and educating presentations from our highly reverend speakers and specialists from various disciplines as related to cancer control and management. The speakers highlighted in their presentations the trajectory of diagnosing, treating, and preventing breast and cervical cancers. And in addition, they also enlightened us on the modern tools that we now have for diagnosing and also for treating the cancers, especially breast and cervical cancer. And this also includes the digital technology that we have now, and also molecular diagnosis that has really helped in improving the diagnosis of breast and cervical cancer. And this has reshaped the landscape for cancer care in the present moment, and also in our own environment here. Well, if you think again about all that has been said today, I would say that this webinar leaves us with many ideas, information, challenges that we have with cancer control in low middle income countries, including Nigeria, and also gives us a reason to vision how we can improve on the prevention and treatment of this disease. So this is something that I would like us to ruminate on as we leave this webinar, and think of how best we, in our own individual way, can contribute to prevention of breast and cervical cancer amongst women. And to do this, one thing that we would really appreciate
as mothers, as women professionals in the medical field, is that you will share the key messages that you have picked from this webinar with your women colleagues, male colleagues, your children, both male and female, because they need to be educated about this. We talk about HPV that can be transmitted even from a man who may have been infected to another woman. So they need, the men and the young males also need to know about this transmission of the disease. And if you ask me what is the main key message of this webinar, I would say that it is screening, screening, and screening for early detection of breast and cervical cancer, so that we can catch it early or even prevent it from developing into cancer if we pick it at the pre-cancerous stage. And we employ all of us here on this webinar to please, at every opportunity, to spread the news, screening, screening, and screening for early detection of breast and cervical cancer. On behalf of the Medical Women's Association of Nigeria, we say thank you so much for being patient with us and for your presence. There will be another person to give a vote of thanks, but I say thank you and goodbye.
Thank you very much, Ma. Thank you very much for staying this long to the end of this program. The theme has been escalating breast and cervical cancer awareness, risk assessment, and screening. We thank the chairman of this occasion, Professor Isaac ADEWOLE. Thank you very much, sir, for gracing this occasion. We thank all our erudite speakers, Professor Millicent Obajimi, Professor Olusegun, Isaac Alatise, Dr. Olutosin Awolude, Dr. Adeleye Omishore, Dr. Omotade Betiku, and Dr. Ayolua Ido. Thank you very much for sharing from your wealth of experience. Thank you to the president of the Nigerian Cancer Association, Dr. ADAMU. Thank you to all MWAN state presidents, the immediate past national president, and to everyone who has made this program a success. We pray that the Lord will continue to keep each and every one of us free of this monster in our families, in Jesus' name. Thank you all. God bless you.
Finally, as the national president, I'd like to thank everybody, all our participants, all our partners, collaborators, donors, the government, the less privileged, all our colleagues, for the support we have received in the last 2 years. We cannot thank you enough. We believe that MWAN moves on, and MWAN is going higher and higher. I would like to single out the IPNP, Dr. Oseji, for her relentless support all the time, and the presence of the new president to take over, Professor Ogu. She's also here. Again, I will emphasize that the executive, the national and the state executives, they have done exceedingly well. I appreciate you all and all members, because we cannot do it alone. A tree does not make a forest. And concerning this cancer, we always say a single stroke does not break down the tree, but persistent, gentle strokes. We have heard from the chairman of the CME, her perception is screening, screening, screening. We all have our different perceptions. Whichever you have, let us follow them intentionally. We are all going to the market. So many roads to the market. When we get there, the right thing is to get what we want and go back home. What we want is eradication, knowing the very, very root cause of cancer, eliminating cancer, saving our girls and women from this monster. We have waited long today. I thank you all, particularly all our resource persons and everyone who has encouraged us to have this webinar. The donation continues, and we would follow up on these donations so that the less privileged women who don't have enough resources to take care of their health will be helped by MWAN. And we will also, in this vein, encourage other NGOs to do likewise. We want to partner with all of you. We should all be on the same page, particularly concerning cancer and women's diseases. Thank you very much for your patience. Thank you for your input. May God bless us all. The IT people, the webmaster, the Zoom people, we appreciate you. Without you, we cannot reach one another. This is a new dimension, and we are benefiting maximally from it. May God bless us all. Thank you very much. Thank you. Closing prayer by Dr. Sambo. If Dr. Sambo is not around, Dr. Fatima Ama Mash. I'm sorry if I'm not calling your name properly. Dr. Sambo or Dr. Fatima? Oh, they were here before. Dr. Adeyemi? Is Dr. Onyida still there? Dr. Onyida Adeyemi? Madina Hassan? Hajara? Is Hajara around? Dr. Onyida Mola Adeyemi, she's still around. Please, can you give us the closing prayer? Please unmute and give us the closing prayer. Her name is there. Yes. No, I don't want to call ZAINAB. Dr. Taufik. Dr. Taufik or Dr. Ajara? Dr. Taufik Tope Adegboyega, please, are you a Muslim? Give us the closing prayer. Anybody in the house who is a Muslim? Any Muslim in the house, please give us closing prayer. In the absence, Dr. Dorcas Taiwola. Dr. Dorcas Taiwola, YGF coordinator. Please give us closing prayer. Dr. Dorcas Taiwola, are you there? Are you communicating, Dr. Taiwola? Can you hear us? Please, can they hear us? Yes. Professor Ogunkunle, please give us the closing prayer. Please check. Yes. Yes. Professor Obajimi. Hello, Professor Obajimi. Please, we can't hear anybody. Professor Obajimi, please give us closing prayer. We can't hear anybody. I think the system is off. Yes, from 20. Okay, Professor Elegbe. Let me call Professor Elegbe. In Jesus' name, Heavenly Father, we thank you for this opportunity to gather for this webinar. We thank you for the joys of the success of this webinar. We thank you for your spirit, outpouring of your spirit of knowledge, wisdom, understanding. We thank you for the skills that you have given all medical professionals and other professionals. Father, you know it all about all these cancers. We call upon you that all what we have had today, we will put it to practice. And Lord, provide for all cancer patients. Let there be ways out for all those who need you, Lord. Thank you, Lord, for all members of MWAN. Thank you, Lord, for all what you have been able to do for us in the last 2 years and yesteryears. As we go to Port Harcourt, oh Lord, prepare us and be with us there and give us